Ever wondered how your brain actually shuts down for sleep? Or, on the flip side, how it manages to calm down from a full-blown panic attack?
Hmm.
It is something we just take for granted. You lay your head on the pillow and, the lights go out, or you take a pill and the anxiety just sort of fades.
Right.
But physically, chemically, what is actually happening in there? And maybe more importantly, why are some sedatives safe enough to have in your medicine cabinet while others are so lethal they're used for lethal injections?
It is a fascinating question. And
Yeah.
the answer really, it comes down to this incredibly delicate balance of electricity and chemistry.
Okay.
It's all about gates opening and closing and ions flowing like water.
Hmm.
But usually when we talk about this, people's eyes just glaze over because we start throwing around terms like hyperpolarization and allosteric modulation.
Yeah.
Without the idea is that the human brain is, well, it's terrible at remembering lists of drug names and mechanisms,
Awful at it.
but it is incredible at remembering places, stories, and, spatial relationships. So I want you to imagine we're stepping into a physical location. It's a resort town,
Okay.
a very specific, very strange resort town that represents the central nervous system, or CNS.
I love this concept. So we are going on a trip to the CNS spa. Our mission today is to explore this spa and the businesses around it. I see a diner, a barber shop, even some futuristic sleep pods, to understand exactly how anxiety, insomnia, and seizures are treated.
And by walking through this landscape, you won't just memorize drug names, you'll visualize the mechanisms. When you see a specific neon sign or a weirdly behaving customer, that's going to lock a complex medical fact into your brain.
Okay, I'm ready to explore. Let's get the lay of the land. What are we looking at here?
Well, the topic is sedation. But to understand sedation, you first have to understand what we are sedating against.
Right, what's the problem we're trying to solve?
Exactly. What is the noise we're trying to quiet down?
Yeah.
So let's look at the wide shot of this resort.
All right.
Now come into the next slide.
Okay, here we are.
Here we are. This is the wide shot of our landscape.
Mhm.
I want you to just take a second and look at this image. It's really a tale of two cities, or like a split screen.
Yeah, it's intense. It's almost like a heaven and hell situation here. On the left side, it looks like just absolute chaos.
Mm.
There are these revolving doors, and people are just rushing in. They look frantic, sweaty, overwhelmed. Everything is red and fiery. There's a sign that says, high stimulation.
Right, and look closer at what those people are doing. They aren't just running, they are eating.
Right.
They are stuffing their faces furiously.
Mm-hmm.
We call these characters the glutton.
The gluttons. Okay. And they are holding these plates piled high with food. What does this gluttony represent in the brain?
The gluttons represent glutamate, and his cousin, aspartate. These are the brain's primary excitatory neurotransmitters.
So they're the on switch.
They are the gas pedal.
Okay.
When glutamate is active, your neurons are firing. It's high stimulation. In a balanced brain, this is focus, memory, and energy. But when it's out of control,
That's the chaos.
that's the chaos. That's anxiety. And in the most extreme case, that is a seizure and electrical storm where the gluttons have just completely taken over.
Okay, so the left side is the too much noise side. It's the panic attack. It's the seizure. Now, look at the right side of the landscape. It's a total contrast.
Yes, this is the CNS spa. The colors, they shift from these angry reds to cool, peaceful blues. There's a beautiful fountain in the middle, people relaxing in white robes, sipping tea. The sign says, quiet zone, relax and recharge.
It looks so peaceful. And who is running this place? I see some staff members kind of floating around looking very zen.
You see those staff members. One has a name tag that says GABA. The other says glycine. These are the heroes of our story today. GABA and glycine are the inhibitory neurotransmitters.
They're the brake pedal.
They're the brake pedal. Their entire job is to turn down the volume. When the gluttons on the left are screaming and throwing food, GABA on the right is a librarian walking over and saying, shh.
So effectively, every single sedative drug we are going to talk about today, whether it's for sleep or anxiety or whatever, is basically just trying to help the staff at this spa do their job better.
Precisely. We aren't reinventing the wheel with these drugs. We are just hiring assistants for the GABA team. We are helping them maintain that calm, blue atmosphere against the red chaos of the outside world.
I really like that fountain in the center. It sort of anchors the whole peaceful side.
Keep your eye on that fountain. It represents the flow of ions that actually creates the calm. But to understand how that water gets flowing, we need to zoom in on the entrance to the spa. We need to see the mechanism.
Okay, let's go.
Now coming to the next slide.
All right, wow.
Okay, we are standing right in front of the entrance to the inhibitory lounge. We're looking at a massive, ornate iron gate.
It's beautiful, and above the gate, there's a sign etched right into the metal. GABA receptor.
This is the most important structure in this entire deep dive, the
Yeah.
GABA receptor. It is a ligand-gated ion channel.
That sounds technical.
It does, but look at the visual. It's a gate. A ligand-gated channel just means it's a gate that needs a key to open.
And I see the key. There's a woman, that's our friend GABA again, and she's standing there pushing a glowing button on the side of the gate.
Right. When GABA, the ligand, binds to the receptor, when she pushes that button, the gate swings open. And look what happens when the gate opens.
Ooh! It's like a dam breaking. There's a rush of water flooding through the gate and into the building. And the water is labeled with these little Cl symbols. That's chloride, right?
Correct. Chloride ions. This is critical physics here. Chloride ions are negatively charged. So GABA opens the gate, and all this negative charge rushes into the neuron.
Okay, so we have negative charge flooding the cell. I think this is where people, myself included, can get lost. Why does adding negative charge calm you down? Why doesn't it excite you or something?
Great question. Let's make it simple. Look at the wall next to the gate. There's a giant thermometer.
I see it. It's huge.
This is the visual hook you need. Look at the mercury in that thermometer. At the top in the red zone, it says hot or depolarized. That represents an active firing neuron. A neuron fires when it becomes more positive. But as that cold chloride water rushes in,
The thermometer is dropping like a stone. It's going all the way down to the bottom, to the blue zone. It literally says freezing and hyperpolarized. There are even icicles forming at the bottom of the thermometer.
that is the physiological result. The influx of negative charge causes hyperpolarization. Think of it as freezing the neuron. When the inside of the cell becomes super negative, super cold, it becomes much, much harder for it to reach the firing threshold. It becomes resistant to stimulation.
So if I'm having a panic attack, my neurons are hot and firing like crazy.
Yes, depolarized.
GABA comes along, opens the gate, chloride rushes in, and the neuron freezes. The panic stops.
Exactly. That is CNS depression. That is sedation. Now, here is the catch. GABA is great, but sometimes she needs help. Sometimes the anxiety is too strong or the insomnia is too stubborn. She needs something to help her hold that button down or, press it more often.
And that is where the drugs come in.
That's where the drugs come in.
We know how the gate works, but there's a popular diner nearby that makes this gate work even better. Let's head over there.
Let's do it. Now come into the next slide.
Okay, I can smell this place.
Let's walk down the street to this diner. It's a classic retro 1950s style place. Neon lights, checkered floors. You can smell the grease in the coffee, right?
Definitely. And look at that neon sign buzzing in the window. It says Benzedines.
Benzedines. Benzodiazepines. This diner represents the benzodiazepine class of drugs. So things like Valium, Xanax, Klonopin. These are the most common drugs used to treat anxiety.
The atmosphere inside is super cozy. It's filled with customers. But I want to point out a very, very specific sign on the wall behind the booths. It says, frequent customers only.
This is your mnemonic. Frequent customers. Benzodiazepines increase the frequency of the chloride channel opening.
Okay, let's unpack that. How does that relate to the gate we just saw with GABA?
Look at the booth in the back. You see our hostess, GABA. She is sitting there. But the customers, the benzodiazepines, are sitting next to her. They aren't taking her spot. They're just joining her at the booth.
So they aren't replacing GABA. They're not pushing her out of the way.
No. And this is absolutely crucial for safety. Benzodiazepines bind to an allosteric site. That just means a separate spot on the receptor. They don't push the button themselves. They just sit next to GABA and say, hey, you're doing a great job. Keep pressing that button more often.
That distinction is huge. So if there is no GABA present, if the body isn't trying to calm itself down at all, the benzodiazepines can't do anything.
Exactly. They are potentiators. They boost the natural signal, but they cannot create the signal from scratch. They increase the frequency of channel opening events, but only if GABA is there to initiate it.
Wow.
That makes them much safer than some of the other drugs we will see later. They have a ceiling effect. You can only potentiate the natural GABA so much before it maxes out.
Ben's Diner is for frequent customers.
Frequency. Got it. Okay, so we are seated at the booth. The waiter's coming over. Let's see what they are serving at Benzedines, because I know doctors choose different benzos for different problems. They're not all the same.
Not at all. Now coming to the next slide.
All right, the menu.
We are looking at a close-up of the diner menu. This is going to help us distinguish between the different types of benzos, because they aren't all the same. It's all about how long they last, their pharmacokinetics.
The first item on the menu is this massive double patty burger. It's called the Die Hard burger.
Die Hard for diazepam, diazepam, or Valium.
And look at the side dish. It comes with a huge pile of active metabolite fries. That sounds ominous. Those fries are key. Diazepam is long-acting. Die Hard implies it lasts a long time, and the reason it lasts so long is represented by those fries. When your body tries to break down diazepam, it doesn't just disappear. It breaks down into active metabolites, desmethyldiazepam specifically, that stick around in your body and keep working even after the original drug is gone.
So you eat the burger is gone, but you're still snacking on the fries for hours and hours.
Exactly. That makes diazepam excellent for conditions where you need steady, long-term coverage, like preventing alcohol withdrawal seizures or managing chronic generalized anxiety where you don't want the patient to have these peaks and valleys of drug effect.
Okay, moving down the menu, here is a tiny, tiny cup of coffee.
Yeah.
An espresso. It's the Midge espresso.
Midge for midazolam. And look at the tagline under it. Gone in a flash.
So this is the opposite. Ultra short acting.
Yes. Midazolam is potent, but it hits fast and it leaves fast. It's usually given IV. This is what they give you right before a colonoscopy or a minor surgery. It knocks you out for the procedure, but you aren't groggy for 3 days afterward.
Makes sense. You don't want a Die Hard burger for a 20-minute procedure.
Mm-hmm.
Okay, the last item on the table isn't food. It's an old leather-bound book. It's called the Lore Book.
Lore for lorazepam, or Ativan. This is our intermediate duration drug, but notice something missing.
There are no fries with the Lore Book, no active metabolites.
Correct. No active metabolites mentioned here. That is going to be very important when we talk about the liver later on. Lorazepam is cleaner in that sense. It's sort of the middle ground of the group.
So we have the Die Hard diazepam, which is long, the Midge midazolam, which is short, and the Lore lorazepam, which is intermediate. The menu covers the timing. But who is eating this food? Let's look around the diner at the clientele.
Yeah, let's see what they're here for. Now coming to the next slide.
Wow, this place is packed.
This scene is bustling. We have a whole cast of characters here, and they represent the clinical uses of benzodiazepines. Why do doctors prescribe them? And there's a mnemonic hidden in the customers. ACDIAZEPAM.
ACDIA. Oh, okay, I see what you did there. That's clever. Let's break down the customers. First, customer A. He's eating a sandwich and he looks incredibly relieved, like a huge weight has been lifted.
That is customer A for anxiolytic. Anxiety relief. That's the most common use. He was probably one of the gluttons outside, panic-stricken, but in the diner, he's calm.
Then we have customer C. It looks like a doctor and a patient sitting in a booth together. The patient is awake, but he looks very relaxed, maybe a little loopy.
Customer C for conscious sedation. This is exactly what we mentioned with midazolam. You are awake enough to follow commands like open your mouth or turn over, but you are sedated and you probably won't remember the procedure. It causes what we call anterograde amnesia.
Next is customer D, another doctor, but this one is holding a map. It looks like a route map for an endoscopy.
Right. Customer D for diagnostic aid, using these drugs to sedate people for uncomfortable diagnostic tests like endoscopies or colonoscopies makes the whole process much more tolerable.
Customer I is pretty obvious. He's passed out face down in his pancakes.
Customer I for insomnia, sleep induction. Although, as we will see, benzos alter sleep architecture, so they aren't always the best long-term choice, but they will definitely put you to sleep in the short term.
Now look at customer A again, the second A. This is a weird one. It's a blender on the counter. It's shaking violently like it's having a seizure, and someone is pulling the cord labeled anticonvulsant.
A for anticonvulsant. This is critical. For status epilepticus, which is a seizure that won't stop, benzodiazepines like lorazepam or diazepam are the first-line treatment. They are the emergency drug you give to stop the shaking blender. They break the seizure.
And finally, customer M. This guy has literally melted into his seat. He looks like a puddle of clothing.
M for muscle relaxant. Benzodiazepines have a central muscle relaxant effect. If you have severe spasms for a back injury or even something more serious like tetanus, these drugs tell the spinal cord to just let go of the muscle tension.
So ACDIAZEPAM covers anxiety, conscious sedation, diagnosis, insomnia, anticonvulsant, and muscle relaxant. That is a really versatile menu.
It is.
Yeah.
But all that food has to go somewhere. It has to be processed. And for that, we have to go to the kitchen. And honestly, this is the part where most medical errors happen, so you want to pay close attention to the kitchen.
Okay, lead the way.
Now, coming to the next slide.
Wow, this is a wild visual.
It is. We are looking at a cutaway view inside a giant liver. This is the liver kitchen.
It looks intense. There are two very distinct stations here. On the left, there's this massive industrial furnace. It's labeled the oxidative oven.
This represents phase 1 metabolism.
Hmm?
Most benzodiazepines, like our diehard diazepam burger, go through this oxidative oven. You can see chefs tossing pills onto a conveyor belt that leads into the fire.
And what comes out the other side of the oven?
Active metabolites. Remember the fries. The oven cooks the drug, but the byproduct is still active. It's still pharmacologically active. These metabolites have very long half-lives. This is why you can feel groggy or hungover the next day after taking something like Valium. The liver processed it, but it didn't finish the job.
Okay, but look at the right side of the kitchen. There is a totally different station. It's labeled the salad station direct conjugation. It looks much cleaner.
This is the exception to the rule, and this is clinically vital. See the character standing there? There's a bull, maybe an ox or a Taurus.
Yeah, a bull. And he's hanging out with, are those kidney beans?
Yes. Kidney beans representing the renal system, or kidneys. And holding a salad bowl is our old friend, the lore book from the menu.
So the lore book, lorazepam, is at the salad station.
This station represents drugs that bypass the oxidative oven. They go straight to phase 2 metabolism, which is called direct conjugation. This includes oxazepam, the oxbowl, temazepam, and lorazepam, the lore book.
OTL, outside the liver, is it the mnemonic?
Exactly. Outside the liver, it's a great mnemonic. These three, oxazepam, temazepam, lorazepam, do not produce active metabolites. They are conjugated, which basically makes them water-soluble, and then they're excreted by the kidneys. It's a much cleaner process.
Why does that matter for the listener? Why is this so important?
Imagine you have an elderly patient. Their liver is old. Their oxidative oven is not working very well. Or imagine a patient with cirrhosis from alcohol. Their liver is failing. If you give them diazepam, it will build up and become toxic because the oven is broken.
Right, they can't clear it.
They can't clear it. But if you give them an outside-the-liver drug like lorazepam, it skips the oven entirely. It's much, much safer for them.
That is a huge clinical pearl. If the liver is cooked, use the salad station. OTL. Okay, the kitchen is busy, but we need to look at the warning signs by the exit. It's not all smooth sailing at the diner.
Not at all. Let's look at the risks. Now come into the next slide.
All right, things are getting a little messy over here.
We are in a chaotic corner of the diner now. These are the adverse effects. We call this scene the floppy rag doll.
It's a little disturbing, honestly. First, there is a mother holding a baby, but the baby looks completely limp, like a rag doll with no stuffing.
This represents floppy baby syndrome. Benzodiazepines cross the placenta. If a mother takes them during labor, the baby can be born with severe hypotonia, which is low muscle tone, and respiratory depression. They can't suckle properly, they can't cry properly. It's a very serious complication.
So use with extreme caution in pregnancy. Got it. Next to them, there's an elderly man. He is slipping on a wet floor sign. He's going down hard.
This connects right back to our liver discussion. The elderly are very sensitive to these drugs. It causes ataxia, which is clumsiness, confusion, and drowsiness. And falls are a major cause of death and disability in the elderly. Hip fractures are no joke. Benzos are a leading cause of those falls.
And finally, a big sign on the wall. A car with a red X through it. No driving.
Pretty self-explanatory. Sedation slows your reaction times. Driving or operating heavy machinery is a definite no-go. It's like driving drunk. In fact, if you combine benzos with alcohol, the effect is synergistic. It's not 1 + 1 = 2. It's more like 1 + 1 = 5. It's incredibly dangerous.
Okay, so benzos are useful, but they have some serious risks. We're leaving the diner now. We're walking down the street to a totally different establishment. This place feels older, dustier, and honestly, a little more dangerous.
It is. Welcome to the barber shop. Now coming to the next slide.
Okay, the barbershop. This feels like a step back in time.
It is. This represents the barbiturates.
Barbiturates, these are the old school sedatives, right? Before benzos took over the market.
Correct. Phenobarbital, thiopendal. They are powerful, they are effective, but they have largely been replaced for most uses. And looking at the shop window will tell us exactly why.
The sign in the window says long-duration haircuts.
Compare that to the diner. The diner was frequent customers for frequency. The barbershop is long duration. Barbiturates increase the duration of the chloride channel opening.
So instead of opening the gate more often, like the benzos did, they just hold the gate open for a much longer time.
Exactly. They prop the gate open, letting massive amounts of chloride flood in. And that leads us to the real danger. Look at the barber standing in the doorway.
He's holding the door wide open. He's not even looking at a customer or anything. He's just holding it open.
This represents the fact that at high doses, barbiturates can directly open the channel, even without GABA. They have what we call GABA mimetic action.
Wait, so benzos needed GABA to be there? They were just cheerleaders. Barbiturates don't.
Correct. Barbiturates can act as GABA. They can force the gate open and hold it open all by themselves.
Which means there's no safety net.
There is no ceiling effect. You can easily overdose to the point where the brain simply stops telling the lungs to breathe. The therapeutic index, which is the gap between a safe dose and a lethal dose, is very, very narrow.
That explains why they fell out of favor. The diner is safer because the hostess has to be there to let you in. The barber shop is dangerous because the barber can just kick the door in himself.
Precisely. But they are still used in specific situations. Let's go inside and meet the staff to see what those uses are.
All right.
Now coming to the next slide.
Okay, 2 barbers on duty.
We have 2 barbers working today. Character 1 is an older gentleman. He's cutting hair while talking on an old-fashioned telephone with a long, curly cord.
A phone. Phyno.
Yes, phone for phenobarbital, or phenobarbital. And he is long-acting.
And what is he used for these days?
He is still used for generalized tonic-clonic seizures, especially in kids or in developing countries where cost is a major issue. But look at what he's doing to the customer in his chair. It's a baby.
He is cutting a baby's hair under a weird blue light. It looks like a tanning bed for infants.
That blue light represents phototherapy for jaundice. Phenobarbital induces an enzyme in the liver called glucuronal transferase. It actually helps the liver clear out bilirubin. So historically, it was used to treat neonatal jaundice. It's a clever little pharmacological trick.
Okay, now look at the second character. This isn't a barber. It's a guy in a mask running out the back door. He's a thief, and he's stolen a pen.
A thief with a pen. Thiopentone, or thiopental.
Ah, clever. Thiopentone.
Thiopentone is ultra-short acting. It was the classic drug for anesthesia induction. You count backwards from 10, and you don't make it to 7. It's that fast.
But why is he running away? Why is he fleeing the scene?
That represents redistribution. Thiopentone works fast because it's very lipid-soluble, so it goes straight to the brain, which has high blood flow. But then, it rapidly redistributes into muscle and fat. That's why the effect wears off so quickly. It doesn't actually leave the body. It just runs away from the brain and hides in the fat tissue.
Got it. The thief runs to the fat hideout. Okay, let's step outside the shop for a second. There is a very loud, very cool car parked out front.
Yeah, you can't miss it. Now coming to the next slide.
Okay, this is a serious muscle car.
This is a hot rod.
Yeah.
It has a massive chrome engine block sticking out of the hood, and the engine is labeled CYP 450.
And that engine is revving incredibly hard. There is smoke just billowing out of the exhaust pipes.
This is a crucial drug interaction point. Barbiturates are potent, inducers of the hepatic microsomal enzymes, specifically the CYP 450 system.
Inducers means they rev up the engine. They put the pedal to the metal on the liver's metabolism.
Yes, they make the liver work much, much faster. They rev up the metabolism for everything.
Why is that a problem? Usually a fast metabolism sounds good.
Not for pharmacology. Look at the smoke coming out of the exhaust. It's blowing over some pill bottles on the ground. I see warfarin, oral contraceptives, digoxin. The smoke is burying them.
So if the liver is revving high, it eats these other drugs too fast and they don't work.
Exactly. If you are on warfarin for blood clots and you take a barbiturate, your liver destroys the warfarin too fast. Your blood gets too thick and you can get a clot.
Or if you're on the pill.
The liver metabolizes the contraceptive too fast and you can get pregnant. It leads to the therapeutic failure of dozens of other drugs. It's a major headache for doctors to manage.
That makes barbiturates really messy to use. Okay, let's go back inside. Because the fumes out here are toxic, but inside, it's even worse.
It is. Now coming to the next slide.
Oh, this is not a clean corner of the shop.
We're in a dirty corner of the shop. This is the stained apron.
Yikes. There is a patient in the chair who looks blue. He looks comatose. And there's a sign on the wall with the dog. Cute little fluffy dog, but it has a big red X over it, and it says no antidote.
That is the scary reality. For benzodiazepines, there is an antidote, which we'll see later. For barbiturates, there is no antidote. If you overdose, we can't just give you a shot to reverse it. We have to support your breathing and hope your body clears it in time.
And the blue patient represents that severe respiratory depression.
Yes, respiratory depression, hypotension, coma. But look at the barber's apron hanging on the hook. It's stained with these weird purple blotches.
The purple stained apron.
This is a very specific contraindication, porphyria. It's a rare genetic disorder involving heme synthesis. Barbiturates induce an enzyme called ALA synthase, which can precipitate a massive, painful, and dangerous attack of acute intermittent porphyria.
Purple for porphyria. Got it. So if there is no antidote and you have this blue guy in the chair who took too many barbiturates, how do we save him?
We have to clean him out using chemistry. We have to give him a wash.
All right.
Now coming to the next slide.
What is happening here?
This is the alkaline wash.
Yep.
We see a rescue worker. He's holding boxes of baking sodium bicarbonate.
And he's pouring the baking soda into a giant tube or a slide. The blue patient is sliding down this tube, which is filled with bubbly blue water.
This represents alkaline diuresis. Barbiturates are weak acids. If we make the urine basic or alkaline by giving AV sodium bicarbonate, we can trap the drug in the urine so it gets flushed out.
How does that work? How does making the urine alkaline trap the drug?
It's a cool bit of chemistry called ion trapping. In an alkaline environment, the weak acid barbiturate molecule gives up a proton and becomes ionized. It becomes charged. Charged molecules cannot cross cell membranes easily, so they can't be reabsorbed by the kidney back into the blood. They're trapped in the urine and peed out.
So we use baking soda to trap the acid drug and flush it out of the system faster. That's very smart chemistry. Okay, that was intense. The barbershop is a rough place. Let's look for a more modern way to get to sleep. Let's visit the futuristic wing of this resort.
Good idea. Much safer over there. Now coming to the next slide.
Okay, this is a totally different vibe.
Welcome to the Z-Wing Sleep Pods. This looks like a sci-fi movie. Everything is sleek, white, and chrome.
There is a sign above the pods, sleep only, no muscle relaxing.
This is the home of the Z drugs. Zolpidem, which is Ambien.
Yeah.
Zaleplon, azopiclone. These are the non-benzodiazepine hypnotics.
Non-benzodiazepines. So they aren't benzos. They work differently.
Chemically, no. Structurally, they look totally different. But T, and this is the key, they bind to the same receptor as the benzos. They just bind more selectively. They really like the BZ1 receptor subtype.
And that selectivity explains the sign? The sleep-only part.
Exactly.
Yeah.
Because they are selective for BZ1, they are pure hypnotics. They put you to sleep. But they have minimal muscle relaxant effects and minimal anticonvulsant effects.
Yes.
You wouldn't use Ambien to treat a seizure or a back spasm. You use it for sleep.
I see the occupants of the pods. They're a weird bunch. In the first pod, there is a zebra.
Zebra for Zolpidem.
In the second pod, an alien. A little green man.
Alien for Zaleplon, which is Sonata.
And in the third pod, is that a giant moth? It's beautiful.
It's a Luna moth for azopiclone, which is Lunesta.
Zebra, alien, Luna moth, the Z team. Now remember the no antidote sign with the dog crossed out at the barbershop?
Mm-hmm.
Look who is playing near the pods here.
It's the little fluffy dog, and he's happy. His name is Flumazenil.
Flumazenil.
Flumazenil is a competitive antagonist at the benzodiazepine receptor. It kicks the drug off the receptor. It is the antidote. It works for benzos at the diner, and it works for Z drugs here in the Z-Wing. It does not work for barbiturates.
That's a huge point to remember. The dog can save the zebra, but he can't save the barber. Let's zoom in on that zebra, because Zolpidem is by far the most famous one here.
It is. Let's look at his dream. Now coming to the next slide.
Okay, the zebra's dream.
We are looking at the zebra's dream. The zebra is fast asleep in his pod, and we can see his dream bubble above his head.
In the first part of the dream, there is a clock spinning really, really fast.
That represents short duration. Zolpidem kicks in fast and wears off relatively quickly. It is ideal for sleep-onset insomnia, people who stare at the ceiling for hours but then stay asleep once they finally drift off.
And in the second part of the dream, the zebra is waking up and flexing its muscles. He looks strong and refreshed. The caption says, "No hangover."
Z drugs are known for promoting a clean sleep. They preserve the deep sleep stages better than benzos do. You're much less likely to feel groggy the next morning compared to, say, taking diazepam.
There is a warning sign on the pod door. It's yellow, and it shows a stick figure walking while asleep, eating a sandwich.
Yeah. This is the notorious side effect. Complex sleep behaviors, sleepwalking, sleep driving, sleep eating. People on Ambien have woken up with crumbs in their bed, having cooked and eaten a full meal they have no memory of. It's rare, but it definitely happens.
That is terrifying. Okay, so Z drugs are for falling asleep. But what if the problem isn't falling asleep, but staying asleep because something is actively keeping you awake?
That requires a whole different strategy. Now coming to the next slide.
Whoa!
We are leaving the futuristic wing and going to a heavy-duty containment area. This is the T-Rex cage.
Whoa! There is a literal T-Rex in a cage, and it is roaring its head off. And the T-Rex is labeled orexin, the wakefulness chemical.
This is a different approach entirely. Instead of trying to boost GABA, which is the calming system, we're going to attack the wakefulness system directly. Orexin, which is also called Hippocratic, is a neuropeptide in your brain that says, wake up, stay awake.
It's the T-Rex screaming in your brain at 3 a.m.
Exactly. So look at the character standing next to the cage. It's a park ranger. He has a giant key, and he is locking the cage door.
He is locking up the T-Rex.
This represents the drug suvorexant. It is an orexin antagonist. It blocks the orexin receptor.
So if you block the wake-up chemical,
You stay asleep. Suvorexant is very effective for chronic insomnia, particularly for sleep maintenance. It stops you from waking up in the middle of the night.
I love that visualization. You aren't just sedating the brain, you are locking up the dinosaur that's keeping you awake. Okay, we have seen all the drugs, but I want to talk about the quality of sleep. Well, you mentioned it briefly with the zebra. Does drug-induced sleep actually look like natural sleep?
That is the million-dollar question. And the answer is usually no. Let's head to the hotel lobby elevators to see why. We are standing in front of the sleep elevator.
Okay.
Now coming to the next slide.
Okay, an elevator panel.
It has buttons for the floors, 1, 2, 3, 4, and the penthouse, which is labeled REM.
REM sleep,
Right.
rapid eye movement. That's the dream sleep, right? The really restorative stuff.
Exactly. Normal sleep cycles through these floors all night. But look at the hand pressing the button. It has a cuff link that says BZD for benzodiazepine.
The finger is pressing the button for floor 2, and it's holding it down. The button is glowing bright orange.
Benzodiazepines do increase total sleep time, yes. But they do it primarily by prolonging stage 2 sleep, which is light sleep.
But look at the other buttons, floor 3, floor 4, which is deep sleep, and the penthouse, REM. They are cracked. They look dusty and broken.
That is the trade-off. Benzos, and especially barbiturates, suppress deep sleep or slow-wave sleep, and they suppress REM sleep. You're asleep, but you aren't getting that high-quality restorative architecture.
And what happens if you suddenly stop taking them after you've been on them for a while?
The penthouse explodes. We call it REM rebound. Because you've been suppressing your dreams for so long, when you stop the drug, the brain floods into REM. You get these incredibly vivid, often terrifying nightmares. That's a classic withdrawal symptom.
So the elevator gets stuck on the top floor and just goes wild. Not fun. Okay, we have toured the whole facility. The spa, the diner, the barber shop, the sleep pods, the T-Rex cage. Let's pull out the map for a final review before we check out.
Let's put it all together. Now coming to the next slide.
All right, the big picture.
Here's the resort map. Let's trace our steps to lock this all in.
We started at the pool gate. GABA opens the chloride channel, which causes hyperpolarization. It freezes the neuron.
Then we went to Ben's diner. Benzodiazepines increase the frequency of that channel opening. Remember, frequent customers. And the antidote is flumazenil, the dog. Don't forget ACDIAZEPAM for the uses.
Then we visited the barber shop. Barbiturates increase the duration of the opening. Long haircuts. No antidote. Much more dangerous.
And you have to watch out for the CYP induction from the revving engine and the porphyria from the purple-stained apron.
Right. Then we went to the Z-wing. The Z drugs are zebra, alien, and moth. They are selective for the BZ1 receptor, so they are pure hypnotics. And the antidote, flumazenil, works for them too.
And finally, the cage. The orexin antagonists, which lock up the wakefulness drive. A totally different mechanism.
And the goal of this entire resort, this whole system,
Is balanced inhibition. Whether it's the frequency at the diner or the duration at the barber, it's all about managing that chloride flow to keep the gluttons on the other side of the street at bay.
it really makes you think about the delicate balance of the brain. We manipulate these ancient chemical systems, opening gates, locking up T-Rexes, just to get a good night's sleep. It shows how, I don't know, how mechanical our consciousness really is.
It's incredible. A few ions in the wrong place and you're anxious. A few ions in the right place and you're dreaming. It's that fine of a line.
Well, I know I'm going to have the image of that melting muscle man and the blue barber stuck in my head forever.
That's the point. It's better than a list of names.
Until next time, keep those ion channels balanced. Thanks for this deep dive.
Stay balanced, everyone.
Imagine for a second that there is a switch, a literal switch on the wall of your reality. And if you flip that switch, you don't just turn off the lights in the room, you turn off the lights in your mind, you delete the recording tape of your memory, you freeze your body so it's completely motionless. And yet, against all biological logic, you stay alive.
It sounds like the premise of a hard sci-fi novel, doesn't it?
Right.
Or maybe some kind of, dark philosophical thought experiment about the nature of existence.
Exactly. If I told you I had a machine in my garage that could do that, you'd probably call the police. But here's the wild part. This isn't fiction. This happens in hospitals every single day, thousands of times a day. We are talking about the fascinating, slightly terrifying, and chemically complex world of general anesthesia.
It is. I mean, it's arguably one of the greatest medical miracles we have.
No question.
I mean, think about the alternative. Without anesthesia, modern surgeries simply wouldn't exist. We would still be in the dark ages, biting on leather straps and drinking a pint of whiskey to get through an amputation.
Which, for the record, is a hard no thank you from me. I much prefer the magic switch. But here's the thing, and this is what we are digging into today. How does it actually work? Most of us just count backward from 10 and, wake up in recovery. But what is happening in that gap? How do doctors safely guide a patient into those deep, dark waters of unconsciousness? And more importantly, how do they bring them back?
It's a journey.
Huh.
And it's not just sleep. That's the first thing to get straight. It is a highly calculated, highly controlled physiological state.
Right.
And to help us navigate that journey today, we are going to use a specific set of visual aids from the research you pulled. We have a stack of 15 distinct slides here, and they visualize this whole process as a deep-sea diving expedition.
I love this metaphor. I really do. We are visiting General Anna's dive shop. The whole deep dive today is going to treat anesthesia like we are gearing up for an expedition to the Marianas Trench.
Precisely. We have a mission today. Our mission is to deconstruct exactly how we submerge the consciousness and resurface it safely. We aren't just skimming the surface, we are going deep into the pharmacology, the physics, and the physiology.
We are going to leave no stone or, I guess, seashell unturned.
I see what you did there.
I try. All right, grab your wetsuit. Are you ready to get wet?
Let's dive in.
Now, let's look at the very first slide. The 4 pillars.
Right off the bat, we are looking at a visual of a wooden dock. We are at General Anna's dive shop. And underneath this dock, supporting the entire operation, are 4 massive concrete pillars.
And there are divers hanging around these pillars. But before we look at the divers, let's define what we are even looking at. I think the average person, myself included before I dug into this, assumes general anesthesia is just a really, really heavy nap, like the best sleep of your life. Is that accurate at all?
That is the most common misconception. People think anesthesia is sleep. It is not sleep. Sleep is a natural cycle with REM phases, dream states, and distinct brainwave patterns. You can be aroused from sleep. Anesthesia is a drug-induced reversible state of central nervous system depression. Basically, it's a coma on a timer.
A coma on a timer, that's a little comforting.
It's controlled. That's the key. And to call it successful anesthesia, you can't just knock someone out with a mallet. That would induce unconsciousness, sure, but it wouldn't be surgery ready. You need to achieve 4 specific structural goals. And those are the 4 pillars on this slide.
Okay, let's walk through the pillars from left to right to understand what the anesthesiologist is actually trying to build. The first pillar is labeled unconsciousness.
This is the primary aim, the big one, reversible loss of consciousness. On the slide, you see a diver floating there, sound asleep with ZZ floating above his helmet. The lights are out. This is what the patient expects, to not be aware of the surgery.
Right, but being asleep isn't enough, is it? Because if I pinch you while you're sleeping in your bed, you wake up. Or you at least pull your arm away.
Exactly. And surgery is a lot more than a pinch. That brings us to the second pillar, which is analgesia.
Looking at the slide, this visual it's terrifying and hilarious at the same time. There's a shark biting the concrete pillar.
But look closely at the pillar. What do you see?
The pillar has a smiley face on it. It's smiling while being bitten by a great white shark.
That is the essence of analgesia. It means freedom from pain. We have to blockade the sensory signals. You see, even if you are unconscious, your body still knows it's being cut.
Wait, really? If I'm unconscious, how do I know?
Well, your conscious brain might not register ouch, but your primitive reflexes do. Your heart rate would shoot up, your blood pressure would spike, you might sweat. Your body would reflexively try to escape the trauma. Analgesia stops that signal dead in its tracks. So the shark bites, but the body, like that smiling pillar, doesn't care.
Okay, that's huge. So we are asleep, and our body isn't panicking from pain. What is the third pillar?
The third pillar is amnesia.
The diver on the slide here is looking at a map and scratching his head. He looks completely confused.
That's the goal. No memory.
Oh.
This is crucial because Believe it or not, there are levels of anesthesia where you might be technically awake enough to hear something, or maybe feel pressure, or your brain might register a sound. But if we have blocked the memory formation, you won't recall it later.
This is the eternal sunshine of the spotless mind part of the procedure.
Precisely. Nobody wants to remember the sounds of the operating room. The saws, the suction, the surgeon complaining about their golf swing. We want all of that deleted.
Absolutely. I do not want to remember the playlist the surgeon was listening to. Okay, so we have unconsciousness, analgesia, amnesia. What is the fourth and final pillar?
The fourth pillar, the final one on the right, is muscle relaxation.
The visual here is a limp wetsuit hanging on a hook, just completely floppy.
And that represents flaccidity. We need the abolition of reflexes. Imagine a surgeon trying to operate on a stomach. If they make an incision, the abdominal muscles naturally want to tighten up to protect the organs. It becomes rigid.
Like doing a crunch.
Exactly like doing a crunch. If the patient has six-pack abs that are tight as a drum, the surgeon can't work. They need the body to be completely relaxed, soft, and pliable, like that empty wetsuit.
So the perfect dive requires you to be unconscious, pain-free, forgetful, and floppy.
Correct. And there is a very important sign hanging on the dive shop wall in this slide. It points to a balanced protocol.
Yeah, I see that. The note says, no single agent achieves all four perfectly.
This is the art of anesthesia. This is so important. We don't have one magic pill that does all four of these things safely. If we gave you enough of a painkiller to make you unconscious, we might stop your heart. If we gave you enough muscle relaxant to stop you from moving but didn't make you unconscious, well, that's horror movie. You'd be awake and paralyzed.
That is literally my worst nightmare.
So we use a cocktail. We mix drugs. Some for induction, some for pain, some for relaxation. We balance the recipe to hit every pillar without knocking down the entire talk.
It's like baking. A pinch of amnesia, a cup of relaxation. Okay, so that's the goal. We know what we are trying to do, but where does this actually happen? Where is the switch in the brain?
To answer that, we have to go inside the hardware. We have to go into the control room.
Now come to the next slide. We are going inside the brain's control room.
This slide is titled Mechanism of Action. It looked like a steampunk submarine interior. And we are looking at a specific part of the brain called the reticular formation.
The reticular formation, that sounds pretty complex.
Think of it as the power strip for your house, or maybe the main circuit breaker. It's located in the brainstem. Its job is to keep the lights on in the cortex, the thinking conscious part of your brain. It is the consciousness generator. If the reticular formation shuts down, you shut down.
Okay, so this is ground zero. We are in the control room of the reticular formation. And I see two very different mechanisms at work here on the slide. They're attacking it from two sides.
Right. On the left side of the room, there is this kind of lounge area labeled GABA cabana.
I love that pun, GABA cabana.
It's a great pun, but it's chemically accurate. GABA gamma aminobutyric acid is the primary inhibitory neurotransmitter in your brain.
Inhibitory, meaning it stops things. It slows things down.
Meaning it slows things down. Think of GABA as the bouncer at a very exclusive club.
Okay, the bouncer.
And this bouncer's job is to tell the brain to chill out. When GABA is active, brain activity slows down. It's the off switch. Now look at the characters in the GABA cabana. You have propofol, barbiturates, and benzos acting like VIP guests.
Yeah, they're massaging the GABA characters, giving them drinks. They look like they are schmoozing the bouncer.
Exactly. Most anesthetics don't turn the brain off directly. They help GABA do its job better. They enhance the inhibition. When they bind to the receptors, they open channels that let chloride ions, which are negative flood, into the cell.
And we see that on the slide. The Cl water is flooding into the room through the portholes on the floor.
Right. Now think about basic electricity. If you flood a room with negative charge, it becomes hyperpolarized. It makes it much, much harder for an electrical signal to fire. The result, the brain goes silent, goes to sleep.
So that's one way to do it. Boost the chill signal. You give the bouncer steroids. But what about the other side of the room? The right side looks a bit more aggressive.
That is the block excitation side. Here we are dealing with NMDA receptors. These are usually triggered by glutamate. If GABA is the bouncer telling everyone to chill, glutamate is the DJ pumping up the volume. It's the brain's party signal. It excites the neurons.
And on the slide, we have these giant red crabs.
Yeah, NMDA crabs. Notice what they are doing. They are clamping down on the transmission cables.
And the lock on the crab's claw says ketamine.
Exactly. Ketamine and nitrous oxide work differently than the other drugs. Instead of boosting the chill signal, they block the party signal. They're antagonists. They clamp onto those excitatory receptors and say, nope, no signal getting through here.
So on one side, we are flooding the room with negative vibes, which is the chloride. And on the other side, we are cutting the cables so the positive vibes, the party vibes, can't get through.
A perfect two-pronged attack on consciousness. You either turn down the volume or you cut the speaker wire. Or in many cases, you do both.
Okay, so we've messed with the control room, the brain is shutting down. What does that process actually look like from the outside? Is it just, quick and you're out?
It feels instant to the patient now, thanks to our modern drugs. But physiologically, it's not instant. It happens in stages.
Now, coming to the next slide, we see the actual dive. This is the descent.
This graphic is fascinating because it's vertically arranged, like a depth chart in the ocean. It shows the 4 stages of anesthesia. Now, these were historically described using ether, which was a slow drug. Modern drugs are so fast we basically skip some of these, but understanding the descent is crucial for safety.
At the top, just under the surface, we have stage 1, analgesia.
The diver is just dipping his toes in here. He is conscious, maybe a little bit drowsy. He can still answer you if you ask him a question, but he doesn't feel pain as sharply.
Yeah.
This is where we might be for very light procedures or right as the gas mask goes on.
But then right below that, the water gets rough. There are jagged waves, and the diver looks like he is flailing. There's a sea mine floating there with the skull and crossbones. This is stage 2, excitement.
This is the dangerous zone. Historically, this was the scariest part of putting someone to sleep. In stage 2, you lose consciousness, so the you is gone. But your lower brain centers, the primitive lizard brain, go into a chaotic override.
The slide calls it sympathetic overdrive.
Yes, fight or flight kicks in. But without the conscious mind to control it, the patient might thrash around on the table, hold their breath, vomit, or cough. Their pupils dilate, heart rate spikes, blood pressure goes erratic.
Wait, so they are asleep, but they are fighting.
Their body is fighting. It's a reflex storm. It's terrifying to watch if you aren't expecting it. And the goal of any modern anesthesiologist is to traverse this zone as quickly as possible. You want to drop through stage 2 like a stone. You do not want to linger there.
So that's why the modern IV drugs work so fast, to just blow right past this part.
Exactly. We want to teleport you from stage 1 to stage 3.
Let's look at stage 3. The water is calm. It's deep blue. There's a clamshell open with a pearl inside. This looks nice.
This is the target zone. Surgical anesthesia. This is where we want to be. The breathing becomes regular and automatic again. The muscles relax, the pupils become fixed, the reflexes are gone. The surgeon can operate here safely.
But the chart goes deeper. There is a stage 3 at the very bottom. It looks like the abyssal zone. There is a graveyard down there with skeletons and shipwrecks.
Stage 4 is medullary paralysis. This is overdose. If you go this deep, you have turned off too much. The respiratory center in the brain shuts down. You stop breathing entirely. The vasomotor center, which controls your blood pressure, fails. The heart stops. This is death.
So the art of anesthesia is keeping the diver floating happily in stage 3 without letting them float up to the stormy stage 2 or sink down to the graveyard in stage 4.
That is the constant balancing act, maintaining that perfect buoyancy. We are constantly tweaking the dials to keep you right at that pearl level.
And to do that, we have a whole arsenal of tools, a whole pharmacy.
We certainly do.
Now coming to the next slide, let's look at the boats and tanks. The drug classification dock.
This slide organizes our inventory. On the left, on the dock itself, we have the inhalational agents. These are the tanks.
I see a big blue balloon that says nitrous oxide.
Right. Nitrous oxide is the only true gas we use. It's always a gas at room temperature. But next to it, connected to those fancy vaporizers, are the volatile liquids.
Halothane, isoflurane, desflurane, sevoflurane.
These come in bottles as liquids, but they evaporate or vaporize very easily. We turn them into a vapor so the patient can breathe them in. So that's group 1, the stuff you breathe.
Then on the right side, floating in the water, we have the parenteral or IV agents. These are the boats.
And notice we have 2 types of boats. We have the speed boats.
Yeah, that sleek white speedboat labeled propofol, and another one labeled thiopentone. Very cool.
These are the fast-inducing drugs. They're built for speed. If I inject propofol into your vein, you will be asleep in 1 arm-brain circulation time.
1 arm-brain circulation time? That sounds like a unit of measurement from a sci-fi movie.
It's a very practical medical unit. It's the time it takes for the blood to travel from the injection site in your arm, up to your heart, out to your lungs, back to your heart, and then up to your brain. It takes about 10 to 15 seconds.
15 seconds. That's
boom. Lights out. It's faster than you can count backward from 10.
Wow. That is incredibly fast. But there are also some slower animals on the dock. There is a turtle labeled benzo and a cat labeled ketamine.
These are the slow-acting drugs.
Hmm.
Benzodiazepines, ketamine, opioids. We use them for maintenance or sedation, but they aren't typically used to slam the door shut on consciousness instantly like the speedboats are.
Got it. So we have the breathers, the tanks, and the injectors, the boats. Let's talk about the breathers first, because there's some really cool physics behind how gases work in the body. And I know physics usually scares people, but this is fascinating stuff.
Oh, physics is my favorite part. It explains everything about why some gases work fast and others take forever.
Now, coming to the next slide, we have to talk a little physics, but fun physics. This slide is titled Physics of Inhalational Agents.
Don't panic. It relies on two simple concepts. The first concept is MAC, minimal alveolar concentration.
On the left of the slide, there is a very confused-looking small diver holding a massive barbell. He looks tiny but strong.
This image explains potency. MA is basically a measure of how much drug you need to knock out 50% of the population. But here's the rule, and this is what trips people up. MDAG is inversely proportional to potency.
Inversely proportional. So a low MACE means high potency.
Correct. Think of it like alcohol. If you have a drink that is pure grain alcohol, it is very potent. You only need a tiny shot glass to get drunk. Small volume equals high power.
Right. Okay.
But if you are drinking very light beer, you need a huge keg to get the same effect. That is low potency. You need a high volume.
So on the slide, the small diver labeled low M is lifting the heavy weight labeled high potency. Small dose, big effect.
Exactly. Halothane has a M-mead of 0.75%. That is a tiny amount of gas in the mixture. It is very strong. But nitrous oxide, its MMC, is over 100%.
Wait, how can you have a concentration of over 100%? That's physically impossible.
Exactly. That means even if you breathed pure nitrous oxide, no oxygen, just nitrous, you still wouldn't be fully anesthetized for surgery. You would suffocate from lack of oxygen before you reach surgical depth.
Yep.
It is a very weak anesthetic.
So nitrous is the light beer of anesthesia.
It's the wine cooler of anesthesia, not even beer.
Okay, that makes sense. Small dose equals strong drug. What about the other tank on the slide? There is a glass tank filled with red liquid blood. And is that an octopus in there?
That octopus represents high solubility. This is the concept of blood, gas solubility.
The octopus is labeled ether, and it looks like it is stuck in the blood. It's grabbing everything.
Think of blood as a sponge. If a drug is highly soluble like ether was, the blood loves it. The blood soaks it all up. The octopus grabs onto the blood cells and doesn't want to let go.
So if the blood is soaking it up, it's not going to the brain.
Precisely. The blood acts like a buffer, like a giant reservoir. If the blood eats it all, you have to keep pumping more and more gas in to finally saturate the sponge so you can get some overflow to the brain. This means induction is slow. It takes a long, long time to fall asleep.
And I guess recovery is slow too.
Agonizingly slow. Because once you turn the gas off, the sponge is still full. It has to squeeze it all back out. It takes forever to wake up.
Now look at the other diver in the tank. The sleek, robotic diver.
That represents low solubility drugs like desilurane or nitrous oxide. The blood ignores them. It's like the blood is Teflon. The drug slides right through.
So the blood doesn't absorb it.
Very little. So the pressure builds up in the lungs immediately and shoots straight to the brain.
So low solubility means fast asleep, fast awake.
Correct. For a modern anesthetic, we want drugs that the blood hates so the brain gets them quickly.
That is so counterintuitive. You'd think you want the blood to carry it, but you actually want the blood to reject it so it gets delivered faster.
Yeah.
Super cool. Speaking of nitrous oxide, let's give the clown his moment.
The laughing gas.
Now coming to the next slide, meet the clown of the group, nitrous oxide.
The visual here is a diver in a clown suit holding a big blue balloon.
We established she is a weak anesthetic with that high XE. He can't put you under by himself, but he has some special tricks. The slide mentions the second gas effect.
This is a team effort. Remember, nitrous has low solubility. It rushes into the blood and then rushes into the brain. Because it moves so fast from the lungs into the blood, it creates a literal vacuum in the lungs' air sacs, the alveoli.
A vacuum, like suction.
Yes. It leaves the lungs so fast, the lungs shrink slightly, creating negative pressure. That vacuum sucks in whatever else is in the mask.
So if you mix nitrous with another drug, like halothane,
The nitrous grabs the halothane and drags it into the blood faster than the halothane could go on its own.
The analogy on the slide is great. It looks like a crowd rushing into a store on Black Friday. The nitrous clown is leading the charge, and he is physically dragging the halothane tank in with him.
Exactly. It speeds up the onset of the other drugs. It's a booster rocket. But there's a dark side to this speed. Look at the tent on the right side of the slide.
The tent says diffusion hypoxia, and there is a warning laid. Give 100% oxygen.
This happens at the end of surgery. This is the reverse of the second gas effect. When you turn off the nitrous, the process reverses. The nitrous rushes out of the blood back into the lungs. And it rushes out with such force and volume that it displaces the oxygen in your lungs.
It crowds out the oxygen.
It floods the lungs. It dilutes the air. If you just let the patient breathe room air after the case, they might become hypoxic, turn blue, because their lungs are full of exiting nitrous instead of oxygen.
So what do? You
have to fill the lungs with 100% oxygen for a few minutes after you turn off the nitrous. You create a buffer zone so that even as the nitrous pours out, there is plenty of oxygen available.
Wow. So you have to flush the system.
Okay, let's move from the clown to the modern professionals. Now coming to the next slide, let's meet the three modern canisters: purple, blue, and yellow.
These are the volatile liquids we use today. And in the operating room, they're always color-coded. You never want to mix these up.
Let's start with purple. Isoflurane.
The maintenance king. On the slide, there's a skunk sitting on top of the purple tank. A skunk? Why? Is it smelly?
It is pungent. It creates an acrid sensation in the throat. If I tried to put a mask on your face with isoflurane while you were awake, you would cough, choke, your eyes would water, and you might have a laryngospasm. Your vocal cords would slam shut.
So you definitely can't use it to start the anesthesia, not with a mask anyway.
Not for mask induction, no. But once you are already asleep, thanks to a nice IV drug, isoflurane is amazing. It keeps you asleep beautifully, it relaxes your muscles, and it is very safe for your liver and kidneys. It's a workhorse, it just has a bad personality.
Okay, next is the blue tank, desflurane.
Desflurane is the fastest. It has the lowest solubility of all the volatiles. That means you wake up instantly. It is perfect for outpatient surgery where we want to kick you out the door in an hour.
But the slide shows lightning bolts coming off it. What's that about?
It is also an irritant, just like isoflurane. It can make you cough. And it requires a special heated vaporizer because it boils at room temperature. It's high-tech, fast, but finicky.
And finally, the yellow tank, sevoflurane.
Ah, Sevo. Sweet and smooth. On the slide, a child is hugging the yellow tank.
Oh.
That's the key. It smells sweet. It is non-irritant. This is the drug of choice for children.
Why specifically children?
Think about it. If a terrified 5-year-old needs surgery, you can't stick a needle in them while they're awake. They'll scream and fight. So we put the mask on with sevoflurane. They breathe the sweet gas, fall asleep gently within a few breaths, and then once they're out, we put the IV in.
It's the gentle giant.
Exactly. Rapid onset, rapid recovery, smells like bubblegum, well, chemical bubblegum.
Okay, so that covers the gases. Now let's talk about the superstar of the IV world. The one everyone knows, mostly because of Michael Jackson, sadly.
Yes, propofol.
Now coming to the next slide, we are looking at the most popular speedboat.
Propofol.
The Propopper. The visual is a futuristic white speedboat.
And the boat itself looks like it's filled with milk.
That is exactly what propofol looks like in the syringe. We call it the milk of amnesia. It is a lipid emulsion, basically oil and water mixed with egg lecithin and soybean oil. It looks just like milk. Why is it the most popular? Is it just because it's so fast?
It is fast, but the quality of recovery is what makes it a superstar. It's unmatched. With older drugs, you woke up feeling groggy, hungover, maybe nauseous. When you wake up from propofol, you feel clear-headed.
The slide says euphoria.
Yes, the feel-good effect. Patients often wake up saying, wow, I had the best sleep of my life. And unlike many other drugs, it is strictly antiemetic.
Meaning it stops you from vomiting.
Huge bonus. Anesthesia usually makes people nauseous. Propofol actually suppresses nausea. It's the gold standard for day surgery because we can get you up, awake, and eating a sandwich in no time.
It sounds perfect. What's the catch? There is a huge anchor dragging behind the boat.
There are always cons. First, hypertension. It drops your blood pressure significantly. It dilates your blood vessels. If you are dehydrated or elderly, propofol can tank your pressure to dangerous levels. Second, apnea. It stops your breathing.
So you inject it and they just stop breathing?
Almost immediately. You have to be ready to breathe for the patient, mask them, or intubate them the second you push that plunger.
And there is a little text arrow pointing to the driver's arm on the boat. It says pain on injection.
Oh, yeah. It burns. It stings like fire going up the vein.
Yeah.
We often mix a little lidocaine numbing medicine with it to take the edge off, but patients will definitely tell you, ouch, my arm is burning, right before their eyes roll back.
Spicy milk.
Exactly.
Okay, let's look at the boat that propofol replaced, the old guard. Now, coming to the next slide, we find an older, rusty contraption, thiopentone.
Lipentone sodium. This is a barbiturate. It used to be the absolute gold standard before propofol came along in the 80s and 90s. We still use it occasionally, but it has really fallen out of favor.
The slide is titled The Barb Wire Trap, and there is a very complex diagram of pipes connecting 3 tanks: brain, muscle, and fat.
This illustrates the concept of redistribution, which is critical to understand. Thiopentone is ultra-short-acting. You inject it, the patient sleeps in seconds. Why? Because the brain, the first tank, gets huge blood flow. The drug hits the brain first.
The brain tank fills up fast.
Right. But then, look at the pipes. The drug starts to leave the brain tank and flow into the muscle and fat tanks.
So the patient wakes up. Why?
Not because the liver broke the drug down. No, the liver's way too slow for that. The patient wakes up because the drug simply moved. It redistributed from the brain to the muscles and fat.
It's hiding in the fat.
Exactly. And this is the hangover problem. Because the drug is still in the body, sitting in the fat tank, the patient feels groggy for hours or even days as it slowly leaks back out to be metabolized. Propofol is metabolized much faster, which is why it's so much cleaner.
There are some scary warning signs on this slide, too. One shows a withered hand labeled arterial spasm.
Thiopentone is highly alkaline. It has a pH of 10.5 that's like bleach. If you accidentally miss the vein and hit an artery, absolute disaster. It causes intense vasospasm. The artery clamps shut. You could lose fingers. You can get gangrene.
Yikes. So accuracy matters a lot. And the other sign, a no backs sign.
That refers to porphyria. Acute intermittent porphyria is a rare metabolic disease. If you give barbiturates to someone with porphyria, it precipitates a massive attack pain, paralysis, madness. Historically, some people think the vampire myths, pale skin, sensitivity to sunlight, receding gums, madness, were actually people suffering from porphyria, hence the no bad sign.
So if you are a vampire, no thiopentone for you.
Got it. Precisely.
Now let's get weird. We are leaving the normal waters and entering a psychedelic zone. Now coming to the next slide, we enter a weird psychedelic cave. This is ketamine.
The dissociative cave. Ketamine is in a class of its own. It's chemically related to PCP angel dust.
The diver in the image looks awake. His eyes are open.
That is the hallmark of dissociative anesthesia. The patient appears awake. They might swallow. Their eyes might be open and moving. We call that nystagmus. But their brain is completely disconnected from sensory input. The lights are on, but nobody is home.
And the diver is super muscular. He has a glowing heart on his chest with an up arrow for blood pressure.
This is why we love ketamine for trauma. Remember how propofol drops blood pressure? Ketamine does the opposite. It stimulates the sympathetic nervous system. It raises heart rate, raises blood pressure, raises cardiac output.
So if someone has been in a car crash and is bleeding out,
You do not want to drop their pressure further with propofol. That could kill them. You use ketamine. It supports their circulation while putting them under. It is the battlefield drug of choice.
the slide also says bronchodilator.
It opens the airways. Great for asthmatics.
But look at the fish surrounding the diver. They are scary neon monsters.
That represents emergence delirium. Because ketamine is a dissociative drug, patients can have bad trips when they wake up. Hallucinations, vivid dreams, confusion. They might think they were dying or floating in space.
So you save their life, but they wake up thinking they were abducted by aliens.
Sometimes, yeah. We can give other drugs like benzodiazepines to dampen that effect, but it's a real risk.
Speaking of benzos, now coming to the next slide, we see 2 scenes, Tommy's Date and Ben's Diner.
We are grouping these two together. On the left, we have a boat called Tommy's Date. This is etomidate.
The character Tommy looks very stable. He is holding a glass of water that isn't spilling even though the boat is rocking.
Cardiovascular stability. That is etomidate's superpower. It is the most heart-stable drug we have. If a patient has a really bad heart condition, severe coronary artery disease or heart failure, and we can't risk even the slightest drop in pressure, we use etomidate.
But Tommy looks like he is twitching.
Yes. Myoclonus. It causes muscle jerks, and it hurts on injection, and it causes a lot of vomiting, but it keeps the heart steady. It's a trade-off.
Okay, and on the right, we have Ben's Diner. This represents the benzodiazepines. Midazolam, diazepam, which is Valium.
This isn't really a boat for deep diving. It's more of a lounge. Benzos are for Anxiolysis killing anxiety.
The people in the diner look very relaxed. They are just chilling, drinking cocktails.
They are sedated. They won't remember the night. That's the amnesia.
Hmm.
But notice they are pinching themselves.
Yeah, why are they doing that?
To show that there is no analgesia, benzos do not stop pain. They just make you not care about it and forget it later. If you cut someone who is only on benzos, they will jump. They are for sedation, not surgery.
And there is a red box on the wall. Antidote? Flumazenil.
That is the safety switch. If you give too much benzodiazepine, you can reverse it instantly with flumazenil. It wakes them up immediately.
Nice to have an eject button. Now coming to the next slide, we have the heavy lifters for pain. Opioids.
We talked about the analgesia pillar earlier. This is how we achieve it. Opioids like fentanyl.
The visual is a fighter jet labeled fentanyl. It looks incredibly powerful.
It is. Highly potent. But notice the massive anchor attached to the jet. And it is dragging down a set of lungs.
Respiratory depression.
This is the curse of opioids. The more you give to kill the pain, the more you suppress the drive to breathe. The patient will simply stop breathing. You have to ventilate them.
And next to the jet, there is a weird robot character labeled Alpha 2.
That is dexmedetomidine, or Precedex. It is a fascinating newer drug.
The text says arousable sedation, and the image shows the robot poking a sleeping patient. The patient wakes up, says hi, and goes right back to sleep.
That is its unique feature. With propofol, you're either out or you are not. With dexmedetomidine, the patient mimics natural sleep. You can shake them, wake them up, ask, does it hurt? They answer no, and then they drift back to sleep.
That sounds incredibly useful for something like brain surgery or just keeping someone comfortable in the ICU.
It is. And the best part, minimal respiratory depression. The anchor is missing. The patient keeps breathing on their own.
But the robot has a warning dial. Bradycardia.
Yeah, it slows the heart rate down. Sometimes too much. There's no free lunch in pharmacology.
Okay, so we have all the drugs. We have our whole pharmacy. But before we even go to the operating room, we have to prep the patient. Now coming to the next slide, let's look at the prep table. Before we dive, we need to pack.
This is pre-anesthetic medication. We don't just wheel you in cold. We prepare the body for the stress of surgery.
There are 5 items on the table here. First, a happy blue blob on a pillow.
That's anxiety relief, usually a benzodiazepine like midazolam. We want the patient calm before they even see the needle. Takes the edge off.
Second, a canteen labeled atropine.
Those are anti-secretions. Drugs like glycopyrrolate or atropine, they dry up your spit.
Why do we want dry spit?
Because if you are unconscious, you can't swallow. If you keep making saliva, it pools in your throat and you might choke on it or inhale it. We want you bone dry.
Item 3 is a bucket, the anti-puke bucket.
Antiemetics. Ondansetron is a common one. Prevents nausea. Essential.
Item 4 is a fire extinguisher putting out a stomach fire.
Those are antacids. We want to neutralize stomach acid.
Why is that so important?
In case you vomit and inhale it, we call it aspiration. If the acid is strong, it destroys your lungs. It's called Mendelssohn's syndrome. If we neutralize the acid, it's still bad to inhale it, but much less damaging.
And finally, a conveyor belt moving boxes labeled empty stomach.
Prokinetics. They force the stomach to empty its contents into the intestines. We want an empty stomach so there's nothing to throw up. Crucial for emergencies when someone just ate.
Smart. Okay, we have prepped, we have dived, we are under, but sometimes things go wrong. Now coming to the next slide, the final one, the dangers.
This slide shows a terrifying boiler room scene, malignant hyperthermia.
The boiler is exploding. The diver is rigid and red hot. This looks bad.
This is a rare genetic nightmare. In some people, exposure to certain triggers like halothane or a muscle relaxant called acetylcholine triggers a massive hypermetabolic storm in their muscles.
The muscles go crazy.
They contract rigidly. They burn oxygen like crazy. They produce massive amounts of CO2, and the body temperature skyrockets. It's a furnace. It will kill you fast if you don't catch it.
But there is a fireman there with a hose.
Yes. The fireman is holding a hose labeled dantrolene.
Dantrolene sodium.
That is the only cure. It relaxes the muscle and stops the furnace. Every operating room must have dantrolene available. It's the law.
And finally, on the right side of this slide, there is a peaceful glass house, conscious sedation.
This is the contrast. This is twilight anesthesia. The patient is in the glass house, protected, sedated, but they can see out. They maintain their own airway. They respond to commands. We use this for procedures like colonoscopies or endoscopies.
Safe, simple, and effective for the right job.
Exactly.
Wow, we have been through the entire dive shop, from the pillars to the pharmacy to the emergency room.
It is a lot of information, but it all connects in the end.
I think we should do a quick speed round. I have some questions here that listeners commonly ask just to nail down the most important points. Are you ready?
Hit me.
Question 1. Let's say a patient comes into the ER, massive car crash, losing blood, in shock. You need to put them under fast. Which induction agent do you reach for?
Answer, you reach for ketamine. Absolutely. You want that sympathetic boost to keep their heart pumping and their blood pressure up. If you gave them propofol, you would crash their pressure and might kill them.
Question 2. Why do we have to give 100% oxygen for a few minutes after we turn off the nitrous oxide?
Answer, to prevent diffusion hypoxia. When the nitrous rushes out of the blood into the lungs, it displaces the oxygen. If you don't flood the lungs with extra oxygen, the patient can become hypoxic just from breathing the air that's being diluted by their own exhaled nitrous.
Question 3. Which drug is the milk of amnesia, and why is it the favorite for day surgeries?
Answer, that is propofol. It is the favorite because it works fast, but mostly because you wake up so clear-headed, the clean head recovery, and it's a powerful antiemetic, so it stops you from vomiting. You get out the door faster and feeling better.
Question 4, last one. You start anesthesia, and suddenly the patient's muscles go rigid and their temperature starts spiking. What is happening, and what is the cure?
Answer, that is malignant hyperthermia. It's a medical emergency. You must stop the triggering gas immediately, call for help, and give the antidote. Dantrolene sodium. Fast.
Well, there you have it. We have survived the deep dive.
We made it back to the surface, hopefully without the bends.
To summarize, anesthesia isn't just a switch. It's a 4-pillar structure built on unconsciousness, pain relief, amnesia, and relaxation. It's a delicate balance of physics, chemistry, and biology.
And it is managed by a pilot, the anesthesiologist, who is constantly adjusting the mixture to keep you floating safely in that surgical zone.
I have a final thought for everyone listening. We spent a whole hour talking about how we turn consciousness off. We know we hit the GABA receptor or we block the NMDA receptor. We know the chemistry. But we still don't really know what consciousness is. We can delete it, we can bring it back. But the actual nature of that spark that makes you you, science is still scratching its head. We are experts at flipping the switch, but we still don't fully understand the electricity.
That is the ultimate mystery, isn't it? We
Yeah.
are working in the dark, effectively.
Something to think about the next time you count backwards from 10. Thanks for taking the plunge with us on this deep dive.
Stay curious.
Welcome back to the deep dive. Today we are doing something a little different. Usually we take you into the boardroom or deep into historical archives or maybe into the latest tech startup. Today, we're taking a trip to the frontier.
We are.
And I don't mean a trip to a library. I want you to picture a landscape. It's dry, it's dusty, the sun is beating down, and maybe there's a tumbleweed rolling by in the distance.
You're setting the mood perfectly.
Yeah.
But, pack your bags carefully, because we aren't going to just any frontier town. We are heading to a place I like to call Sodium Gulch.
Sodium Gulch. I have to say, looking at the stack of visuals you brought in today, 14 slides, all styled like a graphic novel set in the Wild West. I was a bit confused at first.
Yeah, I can see that.
We've got mine shafts, bandits, sheriffs, but the title on the papers is Pharmacology of Local Anesthetics. So are we learning history or are we learning medicine?
We are definitely learning survival. Specifically, we are going to learn how to shut down the human body's electrical wiring. I mean, think about it. Local anesthetics are the only class of drugs that allow you to endure a knife cutting into your flesh while you sit there and, chat about the weather.
Which is insane when you really stop and think about it. Usually, if someone cuts you, your body screams.
Exactly. It's magic.
Yeah.
But to understand how that magic works, how we can turn off a specific part of your body without putting you to sleep, you have to understand the law of the land in Sodium Gulch.
So this isn't just a biology lesson.
No. It's a guide to the drugs that turn off sensation.
We have a big stack of visuals here, 14 slides plus a Q&A wrap-up that break this down using this Western metaphor. And for everyone listening, we're going to walk through these one by one. It's going to be a journey from the dusty surface down into the deep minds of the nervous system.
It's a fascinating journey. We're going to meet the local gang, see how they rob the train, meet the sheriff who tries to keep order, and even deal with some toxic bulls.
I can't wait. Let's ride. Coming to the first slide, Welcome to Sodium Gulch.
Here we are. Set the scene for us. What are we looking at?
Okay, looking at this image, we are staring at a rugged mountain landscape, but right in the center, there is a mine shaft entrance, and hanging over the entrance is a sign that says, voltage-gated Na plus channel.
Na plus for sodium.
Right. There's a track coming out of it with carts full of these glowing blue crystals, and off to the side, there's a group of cowboys, the local gang, holding a banner that reads, Reversible Blockade of Conduction.
Perfect description. This is the fundamental landscape of local anesthesia, that mine shaft. That is the nerve membrane, and the tunnel is the specific channel we are targeting, the sodium channel.
And the glowing blue rocks in the cart, what are those?
Those are sodium ions, Na plus Niana. In the body, these ions are the fuel. They are the coal that drives the train.
Yeah.
You have to understand, your body is essentially a battery. Outside the nerve, there is a massive excess of this positive sodium. Inside, it's negative.
So there's a tension there. The sodium wants to get in.
Desperately. It's an electrochemical gradient. It's like holding back a dam. When a nerve wants to send a signal, say a pain signal from your toe because you stubbed it, that signal travels as an electrical impulse. We call that an action potential.
I remember this from high school biology, the all-or-nothing firing.
Precisely. And for that fire to spread, for the train to move down the tracks towards your brain, these sodium channels have to open up and let those sodium ions rush into the nerve cell. That influx is what we call depolarization.
Okay, so if the sodium rushes in, the train moves, and the brain eventually gets the message and says, ouch.
You got it.
Yeah.
Correct. Now look at our local gang of cowboys. They are the local anesthetics, or LAs. Their entire job is to block that tunnel.
A mine shaft.
Yep. If they can stop the sodium from getting in, the train stops dead in its tracks. The message never reaches the brain.
But that banner they're holding says reversible. That seems important. Why emphasize that so much?
It is the most important rule in the Gulch, the golden rule. We want to stop the train, but we don't want to blow up the tracks. We need the feeling to come back eventually.
Okay.
Unlike a neurotoxin like, say, snake venom, or even alcohol injected directly into a nerve that might destroy the nerve permanently, local anesthetics cause a reversible blockade.
So you feel numb for an hour, maybe two.
And then the sheriff leaves town, and the trains start running again. The feeling comes back completely.
And this is what separates it from general anesthesia, right?
Yep.
Because when I think anesthesia, my first thought is being completely unconscious on an operating table.
Hugely important distinction. General anesthesia is like shutting down the entire power grid of a city. You lose consciousness, you might stop breathing, your brain goes offline.
Right.
Local anesthesia is like setting up a roadblock on one specific street. You are fully awake, you can talk, you can breathe, but the traffic on that one street, your arm, your tooth, your leg, is halted.
So we are basically parking a cart in the tunnel so the sodium train can't get through?
That is the mission. But as we're about to see, parking that cart isn't as simple as just throwing a rock in the hole. You have to be smart to trick the guard.
Let's see who we're dealing with. Now coming to the next slide. Anatomy of a bandit.
To catch a bandit, you have to know what he looks like. You have to understand his structure.
This graphic is great. We see a close-up of a chemical structure that looks kind of like a weapon or a tool. It's labeled Anatomy of a Bandit. It seems to have three distinct parts. There's a head, a tail, and a chain in the middle.
And this represents the chemical structure of almost every single local anesthetic molecule. They all share this blueprint. It's like a skeleton key designed to pick a very specific lock. Let's break it down, starting with the head.
The diagram labels the head as the lipophilic aromatic group. It looks like a heavy, rusty hexagon. Lipophilic, fat-loving.
Exactly. Lipo meaning fat, philic meaning love. This is absolutely crucial. The wall of the nerve cell, the membrane, is made of fat. It's what we call a lipid bilayer.
I see. So if you want to rob the bank, you have to get inside the building first. You have to get through the walls.
Precisely. If you are a water-loving molecule, you just bounce right off that fatty wall. This heavy, fat-loving head allows the molecule to slide right through the fatty wall of the nerve. It's the disguise that gets you through the perimeter fence.
Okay, so the head is the entry pass. It gets you in the door. What about the tail?
The tail is labeled the hydrophilic amino group. Hydrophilic.
Water-loving.
Right.
So one end loves fat, the other loves water. That sounds like a contradiction.
It's a bit of a split personality, and that's intentional. It's a key part of the design. The tail is usually what we call an abendmin. This part is essential because once the drug gets inside the cell, which is a watery environment, the cytoplasm, it needs to dissolve and swim over to the channel.
Ah, so if it was only fat-loving, it would get stuck in the wall.
It would. It would just sit in the membrane forever. It needs the water-loving tail to leave the wall and enter the cell's interior. And more importantly, this tail is the actual stopper that plugs the hole. It's the active part.
So the head gets you in, the tail does the work, and connecting them is this chain in the middle.
The intermediate chain. And notice the label there. It says ester or amide.
Yes. Why does that matter? Is that just, chemistry trivia?
No, this is fundamental. This is family lineage. Every local anesthetic belongs to one of two families, the esters or the amides. The structure of this chain determines everything about how the drug is metabolized, how your body breaks it down, and what kind of allergies it might cause.
I see. So it's like the Hatfields and McCoys, two rival families.
A bit like that. The esters are the older clan. They're more unstable. They break down easily right in the blood. The amides are the newer, tougher bunch. They have to be broken down by the liver. We will get into a very easy trick to tell them apart later, but for now, just know that the chain determines the class.
Got it. Head for the fat, tail for the water, chain to tell the family. Okay, we know what they look like. Now let's see how they work. Now coming to the next slide. Mechanism of action, the inside job.
This is where the plot really thickens. Most people, even some in medicine, think local anesthetics just plaster themselves over the outside of the nerve. Like a piece of tape or a cork in a wine bottle.
That would make the most sense. Block the hole from the outside. Simple.
It would be simpler, yeah. But look at the image. Where is our bandit?
We are inside the mine shaft now. It's dark, there are electric sparks flying everywhere, and our bandit isn't outside. He's inside the tunnel, and he's nailing boards across the door from the inside.
Precisely. It is an inside job. The drug has to penetrate the membrane, enter the cell cytoplasm, and then swim over to the sodium channel and plug it from the inside.
That seems like a lot of extra effort. Why can't it just block it from the front?
Because the receptor site where the drug actually binds is located on the intracellular side of the channel. The keyhole's on the inside of the door. So no entry into the cell means no numbness. It is that simple.
Okay, that explains the intracellular access point on the slide, but I see something else here. There are 3 doors in this tunnel. One is labeled a resting state, another open state, and a third inactivated state.
This is the concept of state dependence. Think of the sodium channel as a door with 3 modes. Resting is closed and locked. The guard is standing there, fully alert, arms crossed.
Not letting anyone in.
Right. Open is when the door is wide open, letting sodium rush in. That's our action potential. And inactivated is when the door is closed but not locked yet. The guard is tired and taking a break after the rush.
And the bandit in the picture is ignoring the resting door. He's attacking the open and inactivated doors.
Exactly. Local anesthetics have a very, very hard time binding to a channel that is in the resting state. It's like trying to tackle a guard who is standing still and bracing himself.
Much harder.
It's much easier to tackle the guard when he's running through the door, open, or when he's catching his breath, inactivated. The drug has a higher affinity for those states.
That makes perfect sense. So the drug works better when the channel is already active.
Which leads us to the third crucial point on the slide, frequency dependence.
The slide says, the more active the nerve, the more accessible the channel is to the drug.
Imagine a door that keeps opening and closing really fast. Every single time it opens, the bandit has a chance to slip in and board it up. If the door stays closed for hours, the bandit is just stuck outside waiting. Now, this is brilliant because, tell me, which nerves in your body are firing the most rapidly when you are hurt?
The ones sending the pain signals, I'd assume.
Exactly. A screaming pain nerve is firing at high frequency. It's opening that door constantly, over and over. So the local anesthetic preferentially blocks the most active nerves first. It targets the pain before it targets a quiet nerve that isn't doing much.
That is incredibly convenient. It's like a smart missile that targets the busiest signal in the area.
It really is. It's an inherent property of the drug. So we call this use-dependent block, which means the more you use the nerve, the faster it gets blocked.
But getting inside isn't easy. We established you need to cross that wall. Now coming to the next slide. The disguise. pH and ionization.
Ah, yes. This is the part that haunts medical students, but we're going to make it simple. This is the ghost versus soldier story.
The visual here is awesome. We have a split screen. On the right, in normal tissue, our bandit is wearing a cloak. He literally walks through the wall like a ghost. Then once he's inside, he throws off the cloak and his chest glows blue with power.
Right.
But on the left, there's a green bubbling pit labeled infected tissue acidic swamp. And the bandit is stuck in the swamp, glowing blue and just bouncing off the wall.
This illustrates the dual personality of the drug. Remember the head and the tail. The drug exists in equilibrium, constantly flipping between two forms. Form 1, the unionized form.
Ghost with the cloak.
Yes. He has no electrical charge. He's neutral. Because he's neutral, he is lipid-soluble. He can walk through the fatty wall. This is the form that allows for penetration.
Okay, so the unionized ghost is the infiltrator.
Right. But once he gets inside the cell, the environment changes. He picks up a hydrogen ion, an H plus syn, and becomes the ionized form. This is the active soldier.
The one with the glowing chest.
He is now positively charged, a charisonic form. He can no longer walk through walls, but he is now powerful enough to plug the channel. This is the form that performs the action.
So, ghost to enter, soldier to fight. You need both forms to get the job done. One can't do the other's job.
Exactly. It's a two-step process. Now, look at the acidic swamp on the left. This represents an infection, let's say a nasty abscess under a tooth.
The dentist's nightmare. Everyone has heard a story about this.
And this is why those stories are true. Bacteria produce acid. Acid is basically a soup of hydrogen ions, H++ Solero. If you inject the anesthetic into this acidic swamp, there are so many H+ ions floating around that they immediately attach to the drug before it can even think about entering the cell.
So they force the bandit to put on the soldier uniform while he's still outside the fortress.
Exactly. And remember, the soldier, the ionized form, is water-soluble, not fat-soluble. He cannot walk through the wall. He bounces right off.
So the bandit gets stuck in the swamp outside the mine. That's what the text on the slide says.
That's the ion trapping effect. The drug is trapped outside in its charged active form, but it's useless out there. This is why if you have a hot infected tooth, the dentist can inject 3 vials of lidocaine, and you might still scream when they drill.
Wow.
The drug physically cannot get inside the nerve to work.
So that's not the dentist's fault. It's just chemistry.
It's chemistry.
So what do? Just let the patient suffer?
No, they have to be clever. Sometimes they can inject the drug much higher up the nerve trunk, far away from the site of infection where the pH is normal. Or, ideally, they have to treat the infection with antibiotics first to clear the swamp before the numbing will work effectively.
Fascinating. So the environment matters as much as the drug. Moving on, we know the drug blocks nerves, but it doesn't block them all at once. Who goes down first? Now coming to the next slide. Fiber susceptibility.
We call this the hierarchy of SEFT. Not all nerve fibers are created equal. Some are easier targets than others.
The image shows a lineup of characters being tied up with blue rope. On the far left, we have a tiny green goblin. He's labeled pain and autonomic. He is tied up completely. In the middle, a shivering guy labeled temperature. And on the far right, a giant, muscular strongman labeled motor. He's barely tied up at all. He's lifting a barbell.
This illustrates the order of blockade. Generally speaking, small fibers are easier to block than large fibers, and myelinated or insulated fibers are easier to block than unmyelinated ones.
Wait, hold on a second. I would have thought insulation protects the nerve from the drug, like a plastic coating on a wire.
You'd think so. It sounds completely counterintuitive. But myelin covers the nerve like a plastic sheath, leaving only small, exposed gaps called the nodes of Ranvier. The electrical signal actually jumps from node to node.
Saltatory conduction.
That's the one. So the drug only has to block those tiny gaps to stop the train. In an unmyelinated nerve, the drug has to block a huge stretch of the surface area to have the same effect. So strangely, a little insulation actually makes the nerve more susceptible to blockade because there are fewer entry points to defend.
Interesting. So the drug just has to hit the weak spots on the insulated one. So let's look at the order. Who falls first?
First to go are the autonomic fibers. These are small, lightly myelinated B fibers. They control things like blood vessel tone. This is why your skin might feel warm or get flushed before it goes numb. Your blood vessels are dilating because the nerves holding them tight have been knocked out.
Then comes the goblin.
Yes, pain. These are the small A delta and C fibers. Sharp pain and dull ache. This is what we want. We want the goblin gone first and foremost.
Then the shivering guy.
Temperature, and specifically cold sensation, disappears before heat sensation. A patient might not feel an ice cube touching their skin, but might still feel a warm coffee mug for a bit longer.
And then?
Chin pressure. This is a huge one for listeners to understand. We often have patients in surgery saying, "Doctor, stop. I can feel you cutting me."
That sounds terrifying.
It is, until the doctor asks, is it sharp pain or just pressure? The patient pauses and says, well, It's pushing. I feel you pushing.
Yeah.
That's because the fibers that carry pressure and touch are larger. They take longer to block. You can be completely pain-free but still feel the pressure of the dentist pulling the tooth.
That is such a vital distinction. It stops panic. The anesthesia isn't failing. It's just that the pressure fibers are still standing.
Exactly. And finally, the strong man. Motor fibers. These are the thickest, heavily myelinated A-alpha fibers. They are the hardest to knock out.
So your muscles are the last to stop working.
And this is key. They are the first to come back.
Yeah.
As the drug wears off, you'll be able to wiggle your toes long before you can feel them.
The strong man breaks the ropes first.
Precisely.
Okay, we understand the mechanism and the order. Now let's meet the specific characters in this gang. Time to meet the sheriff. Now coming to the next slide. Robotoslab prototype, amide. Lignocaine. Lidocaine.
Lidocaine, or lignocaine, depending on where you are in the world. The gold standard, the workhorse.
The visual is a robotic sheriff named Lato. He looks sturdy, reliable. He's standing on a road that has a heart rhythm on it, an ECG strip.
Lidocaine is the prototype amide. Remember the family name.
Yes, the two family.
Here's the trick I promise to identify them. Look at this spelling. Amides have 2 I's in their generic name.
Lidocaine.
See, 2 I's.
Bupivacaine also has 2 I's. Bupivacaine.
Exactly.
Oh, that is a great cheat code. And esters.
Esters have only 1 I, cocaine, procaine.
1 I. Simple. I'll never forget that now.
Yeah.
So lidocaine is an amide with 2 I's. What makes him the sheriff?
He is the most versatile drug we have. He has a rapid onset, he draws his gun fast, he has good tissue penetration. We use him for everything. Topical jelly, injecting into cuts, major nerve blocks, epidurals, spinals. If you go to the ER for stitches, this is what you are getting.
Does it hurt? I always hear about the sting of the injection.
It does sting. Remember the pH from the last slide. Lidocaine in the bottle is kept slightly acidic to keep it stable and dissolved. When injected, your body feels that acid. That's the burn.
So it's not the needle, it's the drug
A
itself.
lot of it is, yeah.
Yeah.
Sometimes we mix a little bicarbonate baking soda, basically in the syringe, to neutralize it so it hurts less on injection.
That's a pro tip. And the heart rhythm rug under his feet? What's that about?
That represents his secret identity. Lidocaine isn't just a local anesthetic. If you inject it intravenously, it acts as a Class 1B antiarrhythmic drug. It stabilizes the heart's electrical system.
So the same mechanism that stops a pain signal in a nerve can stop a chaotic rhythm in the heart.
Exactly. It blocks sodium channels in the heart muscle, calming down the electrical storm of certain arrhythmias. It's a very useful dual-purpose drug. If someone is having a ventricular arrhythmia, we might push IV lidocaine.
But the slide warns about hepatic metabolism. What does that mean for us?
Amides are metabolized by the liver. So if you have a patient with severe liver failure, you have to be very careful. The sheriff might stay in town too long and cause trouble toxicity if the liver can't escort him out.
Got it. Now let's bring in the heavy artillery, or the heavy livestock. Now, coming to the next slide, the bull's bupivacaine versus ropivacaine.
Here come the heavy hitters. These are the ones we respect and frankly fear a little bit.
This image is intense. On the left, we have a massive raging bull with red eyes, snorting smoke. He's stomping on a heart that is shattered into pieces. He is labeled bupivacaine.
Yeah.
On the right, we have a cowboy, looks like a rodeo clown maybe, holding a shield that says motor sparing, standing next to a cute little calf. This is ropivacaine.
This is the tale of the beast and the tamer. Bupivacaine is the wild bull. It is incredibly potent and very long-acting. It can last for 120 to 240 minutes.
4 hours of numbness. That sounds great for long surgeries or post-op pain.
It is. It's fantastic for post-op pain control. But look at what he's stomping on.
The heart.
Bupivacaine is notoriously cardiotoxic. It binds to the sodium channels in the heart, and unlike lidocaine, which jumps on and off quickly, we call that fast in-out kinetics, bupivacaine binds tight and doesn't let go. It's slow in-out.
So it's stickier.
Much stickier. If you accidentally inject this into a blood vessel, it can cause refractory ventricular fibrillation.
Refractory.
It means stubborn. It means you can shock the patient with a defibrillator, give drugs, do CPR, and the heart simply will not restart. It stops the heart dead. It has been called the widowmaker in the past. It is like a shark in the water. Beautiful, powerful, but if it bites you, you are in big trouble.
Terrifying. So why do we even use it?
Because if you put it in the right place, around the nerve, not in the blood, it gives amazing long-lasting pain relief. But you have to be respectful of the bull. You always aspirate, pull back the plunger to make sure you aren't in a vein before you inject.
And ropivacaine, the guy with the calf.
Ropivacaine is the modern upgrade. It's a derivative of bupivacaine, A learner, safer version, it is much less cardiotoxic. If you inject it into a vein by mistake, you have a much, much better chance of saving the patient.
And the shield says motor sparing. What's that about?
This is Ropivacaine's superpower. Remember the hierarchy of blockade. Motor fibers are the hardest to block. Ropivacaine is remarkably bad at blocking motor fibers, but it's still great at blocking pain fibers.
Why is that a good thing? Don't we want to block everything?
Not always. Think about a woman in labor. She's getting an epidural. She wants the pain of contractions to go away, a sensory block. But she needs to use her abdominal muscles and legs to push the baby out. She needs her motor function. If you use bupivacaine, she might have dead legs and can't push effectively. She's paralyzed from the waist down. If you use ropivacaine, you get what's called a walking epidural. No pain, but she can still move.
That is a complete game changer for obstetric.
Huge. Ropivacaine is the tamed bull, strong, but safer and smarter.
Moving from the bulls to the badlands. This next one is infamous. Now coming to the next slide. Cocaine ester.
The original bandit. The OG.
The visual is a crazed-looking prospector. His eyes are glowing blue, and he's obsessively counting a pile of gold coins labeled NA.
Cocaine was actually the first local anesthetic ever discovered. Sigmund Freud was famously obsessed with it, and his colleague Karl Kohler was the first to use it to numb the eye for surgery. Before that, eye surgery was, well, horrific.
I can only imagine. It's an ester. I noticed the one at cocaine. But what's with the gold coins labeled NA?
NA stands for noradrenaline, which you might know as norepinephrine. Normally, your body releases adrenaline at nerve endings and then sucks it back up to recycle it. This prospector cocaine blocks that reuptake pump.
Yeah.
He hoards the adrenaline.
So the adrenaline just piles up in the system.
Exactly. And what does adrenaline do? It races the heart tachycardia, and it clamps down on blood vessels.
Right.
Vasoconstriction. This is the key. Cocaine causes vasoconstriction.
And the others don't.
No. Almost every other local anesthetic lidocaine, bupivacaine, causes vasodilation. They open blood vessels, which is why the site sometimes bleeds more and why we sometimes add epinephrine to them. Cocaine is the only one that shrinks blood vessels all on its own.
Why is that clinically useful? I thought we wanted blood flow.
Imagine you are an ear, nose, and throat surgeon working inside a nose. The nose is full of blood vessels. It bleeds like crazy. If you just touch it, it bleeds.
Okay.
If you apply cocaine solution, you get two effects for the price of one. Anesthesia, the numbness, AE or hemostasis, the tap bleeding. It creates a dry, bloodless field to operate in.
So it's still used medically?
Very strictly, only topically, never injected.
Yeah.
And usually only for nasal surgeries.
Yeah.
But yes, it is still in the hospital pharmacy, locked in a very, very secure safe.
But the risks must be huge.
Massive. Addiction potential, obviously. And because it constricts vessels, if you abuse it, it can cut off blood supply to the heart, causing a heart attack, or to the nose tissue itself. You've heard of people who abuse cocaine having a hole in their nasal septum.
Yeah.
That's because the drug constricted the blood vessels so much and so often that the tissue died from a lack of oxygen. It's essentially gangrene of the nose. It's a very dangerous drug.
From a crazed prospector to a miner who looks a bit sickly. Now coming to the next slide. Prilocaine and EMLA.
Ah, poor Prilocaine. He's the Smurf of the group.
The image shows a miner named Prilocaine. His skin is literally blue. He's shaking hands with our sheriff, Lidocaine, and there's a puddle of cream on the ground labeled EMLA.
Let's start with the blue skin. This is the classic board exam question. Prilocaine has a unique side effect. When the liver breaks it down, it creates a metabolite called otiluidine.
Sounds toxic.
It is. This metabolite attacks your hemoglobin, the protein in red blood cells that carries oxygen. It oxidizes the iron in the hemoglobin, turning it into methemoglobin.
And methemoglobin is bad because...
It can't carry oxygen. So even if the patient is breathing 100% oxygen, their blood isn't carrying it to the tissues. The blood actually turns a chocolate brown color, and the patient's skin turns a slate gray or blue color. We call this cyanosis.
So you numb their arm and they turn into a Smurf. That's terrifying. Can you fix it?
Yes. The antidote is methylene blue, which is pretty ironic. You inject a blue dye to turn the patient pink again.
Yeah.
It reverses the oxidation process.
Wild. Now what about this puddle on the ground, the EMLA cream?
EMLA stands for Eutectic Mixture of Local Anesthetics. It's a mix of lidocaine and prilocaine. Now here is the physics magic. Both lidocaine and prilocaine are solids, they're powders, at room temperature.
Okay.
But if you mix them together in a 1-to-1 ratio, their combined melting point drops below room temperature, and they spontaneously turn into an oil.
Wait, 2 powders make an oil without heating them up?
Yep. It's called a eutectic mixture. And because it's an oil with a super high concentration of the drug, it can penetrate intact skin. Normally, you can't just rub lidocaine on your arm and get numb. Skin is too thick of a barrier. But EMLA cream can soak through the layers.
So this is what they use for kids before putting a needle in.
Exactly. You apply the cream, cover it with a clear plastic sticker, and wait 1 hour. The skin goes numb. No pain for the IV start. It's a real kindness for pediatric patients.
That is cool science. Okay, let's round out the roster, now coming to the next slide. The old guard and specialists.
We have 3 characters here: the retiree, the specialist, and the rule breaker.
First, a rusty, clunky robot labeled Procaine. He's coughing out a cloud of green dust. Second, a kid playing a Nintendo Switch intensely labeled Tetracaine. He has a health bar that says high potency. And third, a guy sitting in a bubbling green pool drinking a flask of acid. This is oxazane.
I'll start with the rusty robot, Procaine. You probably know it by its trade name, Novocaine.
The classic dental drug. Are you numb yet?
It's actually rarely used anymore. It's an ester. And remember, I said esters are unstable. When Procaine breaks down in the blood, it creates a substance called PABA-para-aminobenzoic acid.
I've seen PABA free on sunscreen bottles.
Exactly. PABA is a notorious allergen. It causes severe allergic reactions in a significant number of people. Because of this high allergy rate, Procaine has mostly been retired to the scrap heap. Lidocaine is better, faster, and safer.
Replaced by the amines. Makes sense.
Exactly. Now, the gamer kid, Tetracaine. The name of the game here is potency. Tetracaine is an ester, but it's incredibly powerful and long-acting.
Where do we use this power player?
Spinal anesthesia sometimes, but it's largely used topically in ophthalmology as eye drops or as throat sprays for procedures like a bronchoscopy. It's so strong it numbs the eye almost instantly. But you have to be careful. It's very toxic if you use too much.
And finally, the acid drinker, oxazane.
This guy breaks all the rules. Remember the acidic swamp slide?
Mm-hmm.
We said acidic environments make drugs fail because they get ionized and trapped.
Right. The soldier gets stuck outside the mine.
Oxanthazine is the exception. It is a very weak base that stays unionized, the ghost form, even in highly acidic environments.
And where is the most acidic place in the body?
The stomach. The pH in there can be 1 or 2. So oxanthazine is taken orally, usually mixed with an antacid in a gel called mucain. It numbs the lining of the stomach to treat the pain of gastritis or gastric ulcers. It's the only local anesthetic that can survive the stomach acid and still work.
Incredible. A specialist for the harshest environment. Now, things are about to get serious. We talked about the Widowmaker. What happens when the sheriff goes rogue? Now, coming to the next slide, systemic toxicity, LSD.
This is the most dangerous part of our tour. LAST stands for local anesthetic systemic toxicity.
This happens when the drug gets where it shouldn't be.
Exactly. Usually it happens if a doctor accidentally injects the drug directly into a vein or an artery instead of around the nerve. The drug rushes to the brain and heart.
The slide shows a town in chaos. It's divided into 3 phases. Phase 1, cowboys are dancing on the roof, shaking. Phase 2, they are lying on the ground, sleeping. Phase 3, the bank vault is closed, labeled flatline.
This is the classic progression of toxicity. It's predictable. Phase 1 is CNS excitation. The brain gets confused and starts firing randomly. The very first signs are usually perioral numbness, tingling lips, a metallic taste in the mouth, and tinnitus, which is ringing in the ears.
Listeners, remember that. If you are getting a block and you taste metal, tell the doctor immediately.
Yes. Do not be shy. If you ignore that, the patient starts twitching, tremors, then full-blown seizures or convulsions. That's the dancing cowboys.
In phase 2.
CNS depression. The brain exhausts itself and shuts down. The patient stops breathing respiratory arrest and goes into a coma. The cowboys pass out.
In phase 3.
CVS collapse. The cardiovascular system shuts down. The heart stops. Hypotension, bradycardia, cardiac arrest. This is the flat line. This is what bupropion is so famous for.
So how do we save them? The slide shows a crate labeled RX lipid emulsion.
This is one of the greatest discoveries in modern anesthesia and toxicology. We used to just do CPR and hope for the best. Now we have intralipid. It is literally a bag of sterile fat, usually soybean oil. It looks like milk.
Why fat? How does fat help?
Remember the bandit structure. The head is lipophilic. It loves fat. If you infuse a bunch of fat into the blood, it acts like a lipid sink.
A lipid sink?
Think of it like a grease trap or a sponge.
Yeah.
The local anesthetic molecules that are poisoning the heart and brain leave those tissues to go swim in the fat globules because they love fat so much. It literally pulls the poison out of the tissues and traps it in the blood until the liver can clear it.
That is brilliant. You scrub the blood with fat.
It works miraculously. It has brought patients back from what was previously considered certain death. Every location that uses local anesthetics should have a bag of intralipid nearby.
Okay, we've covered the drugs and the dangers. Now let's talk about where we put them. We're going deep underground now. Now coming to the next slide. Spinal anesthesia.
We are leaving the peripheral nerves and going right to the central nervous system. The mother lode.
The visual is a cowboy sitting in a glass tank full of water deep in a basement.
The basement is the subarachnoid space. This is the space surrounding your spinal cord, and it's filled with cerebrospinal fluid, or CSF. In spinal anesthesia, we inject a small amount of drug, usually bupivacaine or heavy lidocaine, directly into this water tank.
The slide notes the level below L2. Why is that so specific?
It's crucial. The spinal cord itself usually ends at the L1 or L2 vertebra. Below that is just a bundle of dangling nerve roots we call the cauda equina, or horse's tail. We stick the needle below L2, usually at L3, L4, so we're poking into the floating noodles, not the solid cord itself. You don't want to stab the spinal cord.
Good plan. What happens when you put the drug in the tank?
It mixes with the CSF and numbs all the nerve roots in that area. It creates a very dense, very profound block. Your legs turn to cement. You can't move, you can't feel. It's perfect for C-sections, knee replacements, hip replacements, things like that.
But the slide lists complications. Hypotension is in big letters.
Remember the goblin, the autonomic fibers. They get blocked first. When you block the sympathetic nerves to the legs and gut, all the blood vessels dilate wide open. The blood pools in the legs, and blood pressure drops rapidly. We have to be ready to treat that with IV fluids and vasopressors immediately.
And this poor cowboy in the tank looks like he's in pain. There's a thundercloud over his head labeled post-dural puncture headache.
PDPH. To get into the tank, you have to puncture the dura, which is the bag holding the fluid. Sometimes after the needle comes out, that little hole doesn't seal immediately. CSF leaks out like a slow puncture in a tire.
Okay.
This lowers the pressure in the brain and spinal column. When the patient stands up, gravity pulls the brain down, stretching the sensitive tissues and causing an agonizing headache. When they lie flat, it goes away.
The spinal headache. I've heard of that.
And one last danger, high spinal. If the drug floats up too high in the tank, say up to the neck, it can block the phrenic nerve roots that control the diaphragm, which come from C3, C4, C5. The patient stops breathing. Respiratory paralysis.
So you have to position the patient carefully so the drug doesn't float up.
Gravity is our friend and our enemy here. We use it to control the level of the block.
Different tools for different jobs. Now coming to the next slide. Techniques of local anesthesia.
This slide compares two other common techniques we use all the time.
On the left, we have epidural. It shows a snail. On the right, Beer's block, which shows a clock and a tourniquet on an arm.
Let's start with the snail, the epidural. Unlike the spinal, we are not entering the water tank. We're injecting into the epidural space, the fatty space outside the dura bag. The drug has to soak through the dura to reach the nerves.
Is that why it's a snail? It's slow.
Yes. It's slower onset, maybe 10, 20 minutes compared to spinal, which is almost immediate. And you need a much larger dose because it has to diffuse. But the huge advantage is you can thread a tiny plastic tube, a catheter, into that space and leave it there. You can pump drug in continuously for days.
So that's why it's ideal for labor analgesia.
Exactly. You can keep it running as long as labor lasts, adjusting the dose as needed.
Okay, snail. Slow but continuous. Now, the Beer's block, that looks intense.
IV regional anesthesia. This is very clever. Let's say you need to fix a broken wrist. You put a tourniquet on the upper arm and inflate it tight. No blood in, no blood out. Then you inject lidocaine into a vein in the hand.
Into the vein. But you just spent 10 minutes telling us that causes toxicity.
Normally, yes. But the tourniquet traps the drug in the arm, it fills the veins in the arm, and soaks backward out of the veins and into the tissues and nerves. The entire arm goes completely numb.
But you can't let the tourniquet down, right?
That's the clock warning. Do not release 20 mins. You must keep the tourniquet up for at least 20 minutes. This gives the tissues time to absorb the drug from the blood. If you release it immediately, a huge bolus of lidocaine shoots straight to the heart, cardiac arrest.
That is a high-stakes procedure.
And notice the drug rule. Never use bupivacaine for a Beer's block.
Because bupivacaine is the cardiotoxic bulb, that makes perfect sense.
Right. If the tourniquet fails with lidocaine, the patient might seize, but we can probably manage that. If it fails with bupivacaine, the patient dies. So we only use lidocaine or prilocaine.
Safety first. Speaking of which, let's wrap this up. Now, coming to the next slide, sheriff's checklist.
Mission complete. Let's review the final orders.
The sheriff is holding a scroll with 6 key points. Number 1, target.
Ni plus channels. The voltage-gated sodium channels. And it's an inside job. Remember the bandit entering the mind?
Number 2, chemistry.
Esters, one eye, allergy risk from PEBA, versus amides, two eyes, liver metabolism.
Number 3, environment.
Acidic or infected tissue equals failure. The ion trapping effect prevents the drug from getting inside the nerve.
Number 4, the hero.
Lidocaine. Safe, versatile, our workhorse, and it doubles as an antiarrhythmic.
Number 5, the villain. Or maybe just the beast.
Bupivacaine. Potent and long-lasting, but highly cardiotoxic. Respectable.
And finally, number 6, safety.
Aspirate before injecting. Always pull back to make sure you aren't in a blood vessel. And the classic rule, no adrenaline on fingers, toes, penis, or nose, which are end arteries, to avoid gangrene, though that's a bit of a controversial rule these days. It's still a classic teaching.
Fantastic summary, but we aren't done yet. The townsfolk have questions. Now coming to the final section, most important questions.
Let's hit the Q&A. These are the high-yield points, the things you absolutely have to know.
Question 1. Why doesn't local anesthesia work on a hot, infected tooth? We covered this, but let's nail it down one last time.
It's the pH. Infection creates acid. Acid creates a flood of hydrogen ions. The drug gets protonated or charged outside the nerve membrane, and then it just bounces off. It cannot penetrate to the binding site. It's the soldier stuck in the swamp.
Question 2. How do you tell an amide from an ester just by the name?
The I rule. If the generic name has two OIs, like lidocaine or bupivacaine, it's an amide. If it has only one I, like procaine or cocaine, it's an ester.
Question 3. If a patient starts having seizures after an injection, what is the first drug to grab?
Well, first you secure their airway, give oxygen, and you'd give a benzodiazepine like midazolam to stop the seizure. But the specific antidote for the underlying toxicity is lipid emulsion, Intralipid, get the fat bag.
Question 4. Which drug causes the patient to turn blue?
Prilocaine. It causes methemoglobinemia, and you treat it with methylene blue.
And question 5. Why is ropivacaine preferred over bupivacaine for labor?
2 reasons, really. 1, it's safer, less cardiotoxic. But the main clinical reason is motor sparing. It provides excellent pain relief, a sensory block, but it spares the muscle strength, the motor block, allowing the mother to actively push during delivery.
And with that, we have survived sodium gulch.
We made it out without any systemic toxicity, I hope.
I certainly feel smarter. It's amazing to think that this whole complex world of ions, pH, and bandits is happening every single time someone gets a few stitches at the doctor.
It really is. And I'd like to leave the listener with a final thought. We've come a long, long way from chewing coca leaves or injecting toxic esters. We have these smart drugs like ropivacaine now.
Yeah.
But imagine the future. What if we could design a bandit that only targets the specific subtype of sodium channel found on pain fibers, like the NaV1.7 channel, and completely ignores all the motor and heart channels?
Wow.
We could have perfect, complete pain relief with zero numbness, zero paralysis, and zero cardiotoxicity. That is the holy grail that researchers are hunting for right now.
A bandit that only steals the pain. I like the sound of that. Until then, keep your sodium channels open, unless you're in surgery. Thanks for listening to The Deep Dive.
Stay safe out there.
Hello and welcome back to The Deep Dive. Today we're doing something a little different. We're not just, reading research papers or highlighting texts.
No, not at all.
We are constructing a memory palace.
I like that. A memory palace.
Yeah, because if you've ever tried to memorize pharmacology, especially the drugs for, say, alcohol and epilepsy, it can just feel like this graveyard of unpronounceable names.
And random side effects that don't seem connected to anything.
Exactly. So we're going to fix that today. We are taking a literal tour of a fictional place we're calling Neurotown.
That's right. It's a bustling fictional town that we've designed to help us all visualize something that's really invisible.
And what's that?
The complex biochemistry of how your body handles alcohol, and then how we tame the electrical storms in the brain that we call seizures.
We have a stack of illustrations here. It's really a map, and we're just going to walk through them one by one. And it's going to start simple. I mean, almost like a storybook.
Very simple.
But by the time we leave town, you're going to understand some pretty advanced medical mechanisms that honestly take medical students years to really master.
We'll cover the biology of a hangover, the lethal mistake of drinking moonshine, and then we'll cross the tracks to the electric rodeo.
The electric rodeo.
And that's where we'll learn how to control the chaos of epilepsy.
So put on your walking shoes, I guess. Let's look at this first visual, now coming to the next slide.
Okay, so this is our overview map. It's a split world.
Right, I see it.
On the left, you've got this dusty Western-style zero-order saloon.
Hmm.
It looks, hot, dry, slow-moving.
Mm-hmm.
And on the right, across the tracks, there's this neon-lit, vibrant theme park. That's the Electric Rodeo.
Okay, let's start with the saloon. It says zero order right on the sign. Why that specific name?
Well, that refers to zero-order kinetics. This is the fundamental rule of how your body deals with alcohol.
Zero order kinetics.
Yeah. Imagine a bartender who's just cleaning glasses. He can only clean one glass per minute. It doesn't matter if there are 5 people waiting or 500 people waiting.
He's still only cleaning one glass a minute.
He can only clean one glass a minute. That's your liver.
So unlike other drugs where, your body might clear them faster if you take more, alcohol has a fixed speed limit.
Exactly. You cannot rush the bartender. And this is why alcohol toxicity can build up so easily. If you drink faster than he can clean, the backlog just accumulates immediately.
Right. And the electric rodeo on the other side?
That represents seizure control. Seizures are, they're essentially uncontrolled electrical firing in the brain.
All that energy.
All that energy. The rides, the flashing lights, the mechanical bulls. It's all about chaotic energy.
Hmm.
Our job with medication is to regulate that energy so the rodeo doesn't, burn down.
But without cutting the power cord completely so the person can still function.
Precisely. It's a balancing act.
The slow burn of the saloon versus the high voltage of the rodeo. Okay, let's start our tour on the dusty side of town. Now coming to the next slide.
Here we are, inside the distillery. This visual explains exactly what happens chemically when you have a drink.
Okay, it looks just like a moonshine factory. I see a big copper tank labeled ethanol, and there are pipes leading to a second tank, and that one's labeled acetaldehyde, and it's full of this glowing green, sick-looking goo.
That green goo is the villain of our story.
The villain.
When you drink ethanol, doesn't matter if it's fine wine or cheap beer, an enzyme called ADH, that's alcohol dehydrogenase, turns it into acetaldehyde.
The green goo.
The green goo. And that stuff is highly toxic. It's what causes the nausea, the flushing, the headache.
So it's basically the hangover molecule.
Precisely. But, usually you don't stay feeling terrible forever, and that's because of the next step in the pipeline.
Okay.
A second enzyme, aldehyde dehydrogenase, quickly takes that nasty green goo and turns it into acetate.
Which is harmless.
Which is harmless. Your body could just get rid of it.
So it's a two-step factory line. Ethanol to toxic green goo, then toxic goo to harmless acetate.
Correct. But now, look at the character standing in the middle of the factory floor. He's a sheriff, and he's holding a shield that says, desulfurum.
And he's blocking that second pipe. He's stopping the cleanup crew.
Yes. Desulfurum is a drug we use for alcohol use disorder. It creates a bottleneck. It allows the body to turn alcohol into the toxic green goo.
But it stops the body from getting rid of it.
Exactly. It prevents the cleanup.
That sounds dangerous. What happens if a patient drinks while they're taking this drug?
Well, the acetaldehyde piles up almost instantly. Within minutes, the patient experiences violent vomiting, a pounding headache, sweating, confusion. It is miserable.
So you're weaponizing the hangover.
That's a great way to put it. It's called aversion therapy. You are using the body's own metabolic poison as a deterrent. The patient knows that if they take even a tiny sip,
They're going to feel like they're dying.
right, so they avoid the alcohol.
That is a powerful image. The sheriff forcing you to sit with that toxic mess.
Okay, let's step outside the distillery. It looks a bit colder out here. Now coming to the next slide.
We are still on the alcohol side of town, but yeah, this is the dangerous side of the street. This visual is titled Methanol Poisoning.
It's a snowy scene. I see a lumberjack-looking guy holding a jug of methanol, and he looks like he's in serious trouble.
Yeah.
There are red ants biting his feet.
Yes, red ants. And notice he's staring out at a field of white snow.
Right.
This is a true medical emergency. Methanol is wood alcohol, often found in antifreeze or, poorly distilled moonshine. It goes through the exact same factory line we just saw.
The same ADH enzyme.
The same one, but the output is very different.
It doesn't make the green goo.
No. The first enzyme turns methanol into formaldehyde, which is, what we use to embalm bodies,
Oh, wow.
and then into formic acid.
Formic acid, isn't that the venom in ant bites? Exactly. That's why we have the red ants biting his feet in the picture. It represents metabolic acidosis. The blood becomes dangerously acidic from all that formic acid.
And the snow feel? Why is he looking at snow?
Because formic acid is selectively toxic to the optic nerve. It causes snowfield vision, a blurriness that looks like a blizzard, which then progresses rapidly to total permanent blindness.
That is terrifying. So if someone comes into the ER and says they drank some moonshine and now it looks like it's snowing.
You have minutes to act. You have to shut down that factory line immediately.
I see the rescue team here. There's a fireman spraying a foam extinguisher labeled Foamazole.
Foamazole is the antidote. It's the preferred treatment. It directly inhibits that very first enzyme alcohol dehydrogenase. It stops methanol from ever being converted into the acid.
But there's another guy here. He's offering the lumberjack a bottle of regular whiskey. That seems totally counterintuitive.
You're poisoned by alcohol. Here, have a shot. It sounds crazy, but it's real science.
Yeah.
The enzyme, ADH, it actually prefers regular ethanol over methanol. It has a much higher affinity for the good stuff.
So you're just distracting it.
You're distracting it, you flood the system with whiskey, the enzyme gets busy processing that, and the methanol just passes through the kidneys without ever turning into poison.
So you distract the liver with a party to save the eyes?
It's competitive inhibition at its finest.
Amazing. Okay, let's leave the snow and the saloon behind. We are crossing the tracks. Now coming to the next slide.
Welcome to the electric rodeo. This is where we're going to visualize epilepsy.
This visual is fantastic. We've got a whole mechanical bull ride set up in the center. There's this massive raging mechanical bull. And then off to the side, there's a much smaller kiddie ride mechanical horse.
This illustrates the two main categories of seizures. The little mechanical horse is a partial seizure. It's focal. Only one part of the brain is misfiring, just like only one small ride is moving. The person might, twitch a hand or smell something strange like burnt rubber, but they're often awake.
And the big bull, that's the main event.
That's a generalized seizure, specifically a tonic-clonic seizure. The whole bull is bucking, meaning both hemispheres of the brain are involved. The electrical storm is everywhere.
And consciousness is lost, the body convulses.
Right.
Okay, now the fence in front of the bull, this is really detailed. It says the neigh plus gate for sodium. And there are 3 gates here.
This is maybe the most important concept in all of Neurotown. To stop the bull, to stop the seizure, we have to control the sodium, or neigh plus gach, channels. These channels are what let electricity flow into the nerve cells.
Okay, so walk me through the 3 gates.
First, on the left, you've got the open gate. Sodium rushes in. That's the spark. That's the neuron firing.
Got it.
Then in the middle, you have the closed gate. It's shut, but it's ready to pop open instantly if someone knocks. We call that the resting state.
And the third one. It's different. It has a ball and chain on it.
That is the inactivated state. The gate is closed, and a physical protein ball and chain has swung up to plug the hole from the inside. And this is crucial. A channel in this state cannot open no matter what. It is locked. It is taking a timeout.
So if I want to stop a seizure, which is basically neurons firing way too fast.
You want to extend that timeout. That's the whole game. High-frequency firing relies on those gates opening and closing almost instantly. Most anti-epileptic drugs work by just grabbing that ball and chain and holding it in place for a fraction of a second longer.
And that breaks the rhythm of the seizure.
It breaks the rhythm. It forces the bull to take a break.
That makes the mechanism so much clearer. So let's meet the drugs that actually do this. Now coming to the next slide.
Here is one of the oldest and most reliable drugs in town. Visual number 5, carbamazepine.
Okay, it's drawn as a classic car, a vintage Chevy, and there's a driver leaning against it, and he looks like he's in pain, who's holding his jaw.
That pain is a very specific clue. Carbamazepine is the #1 drug of choice for trigeminal neuralgia,
Which is?
a condition that causes severe lightning bolt pain in the jaw. It works on the sodium channels there too, not just in epilepsy.
But it's also for seizures.
Oh yeah, for partial seizures and for generalized tonic-clonic seizures. It works by stabilizing that inactive state we just talked about. It locks the gate.
I noticed something about the car itself. The hood is open, the engine is shaking, and the caption says, auto-induction.
This is a really unique and, frankly, tricky feature of carbamazepine. It acts like an engine that revs itself up.
What does that mean?
When you take this drug, it stimulates the liver enzymes that break it down. So over the first few weeks, the drug actually eats itself up faster and faster.
So the more you take, the faster your body gets rid of it.
Exactly. You often have to increase the dose after a few weeks because the engine just gets too efficient at clearing it. It's called auto-induction.
And what about the back of the car? There's water leaking out of the tailpipe?
That represents the side effects. It can cause the body to retain water by acting like the hormone ADH.
Yeah.
And this can dilute your blood sodium.
Leading to that hyponatremia we talk about.
Right. And you can see the driver looks a bit dizzy.
Yeah, he does.
Vertigo and double vision are classic side effects. So remember the classic car. Fixes jaw pain, but it leaks water and revs its own engine.
Got it. Let's move to the food court now and meet a very different character. Now coming to the next slide.
Sodium valproate. This slide is titled The Welcome Festival.
We have this large, jolly-looking chef standing in a booth, and he's got everything. I see a shield that blocks sodium, a bottle of calcium, and his apron says GABA.
We call him the broad-spectrum chef
Yeah.
because he does it all. Valproate is a really unique drug. It blocks sodium channels, so it stops the bowl.
All right.
It blocks calcium channels, and it boosts GABA, which is the brain's main calming chemical.
So because he has such a big menu, he can treat a lot of different kinds of seizures.
Exactly. He welcomes everyone. Absence seizures, myoclonic seizures, tonic-clonic seizures.
Ah.
If a doctor isn't exactly sure what kind of seizure a patient has, Valproate is often the go-to broad-spectrum answer. It covers all the bases.
But the chef looks a little unhealthy. He's quite overweight, and he seems to be losing his hair.
Unfortunately, those are the side effects. Valproate is well known for causing significant weight gain and alopecia, which is hair loss. It can also be pretty tough on the liver.
And look at that sack of beans he's spilled on the floor. They're spilling out in a very specific shape.
They form the shape of a spine with a gap in it. And it says spina bifida.
That seems like a very serious warning.
It's the most critical warning in all of Neurotown. Valproate is highly teratogenic,
Ringing.
meaning if a pregnant woman takes this, it can interfere with the baby's neural tube development, causing severe birth defects like spina bifida.
So absolutely forbidden during pregnancy.
Correct. It is a fantastic drug for stopping seizures, but a very dangerous one for a developing fetus.
Okay, noted. Let's move to a quieter, more specific part of the rodeo. Now coming to the next slide.
Visual number 7 is ethosuximide, and it's depicted as a tea party.
A very different vibe. There's a little boy sitting at a table, and he's just staring blankly into space. He's not convulsing or shaking at all.
That represents an absence seizure, which used to be called petit mal. Very common in children. They don't fall down. They just zone out for a few seconds, sometimes tens of times a day.
And the treatment. I see a waiter pouring tea from a pot with gears in it.
The mechanism here is totally unique. It blocks something called thalamic T-type calcium currents.
T-type for tea party.
Exactly. The mnemonic we use is ethosuximide sucks up the T currents. It stops that rhythmic brainwave in the thalamus that causes this staring spell.
So does it work for the big mechanical bowl seizures, the tonic-clonic ones?
No. And that's the catch. It is a precision tool. It only works for absence seizures. If you give it to the bull rider, it won't do a thing. It's tea, not a sedative.
Sucks up the T currents. I will remember that. Okay, let's go to the relaxation zone. Now coming to the next slide.
Here we have the benzodiazepines and barbiturates relaxation booth.
This looks cozy. A tent with big fluffy pillows, and the sign says, Target, GABA, a receptor.
So GABA is the brain's main inhibitory neurotransmitter. Its job is to tell the brain to chill out.
Right, the calming chemical.
Exactly. It does this by opening a channel to let chloride ions in. Chloride is negative, so it makes the neuron more negative and much harder to fire.
I see two characters running this booth. On the left, a showgirl named Gabby for benzodiazepines, and on the right, a strongman barber for barbiturates.
This is a classic pharmacology distinction. Both of these drug classes make GABA work better, but they do it in different ways.
Okay, the poster next to Gabby says increased frequency.
Right. Benzodiazepines, like diazepam or lorazepam, make that chloride channel open more often. They increase the frequency. Think of Gabby chatting away, opening the door again and again and again.
And the barber. His poster says increased duration.
Barbiturates, like phenobarbital, they are the strongmen. When they grab the channel, they pry it open and they hold it there for a long time. They increase the duration it stays open.
So benzos make the door flap open frequently. Barbiturates pry it open and hold it. Why does that difference matter so much?
Because the barber holds it open for so long, barbiturates are much, much more dangerous in an overdose. They can shut down the brain too much, leading to coma or even death.
Whereas benzos have a ceiling effect.
They do. The barbs don't. That's a crucial safety distinction.
Got it. Let's check out the new technology, now coming to the next slide.
We've arrived at the newer anti-epileptics. These are the modern machines, and we have 3 booths here.
Okay, booth 1 is the llama show. It's a llama with red spots all over it.
This is lamotrigine. It's a great drug, blocks sodium channels just like the classics. But the llama has spots for a very important reason.
The spots are a warning.
They are. It carries a risk of a severe, potentially life-threatening skin rash called Stevens-Johnson syndrome.
So you have to start low and go slow with the dose to avoid the spots. Okay. Booth 2 is the amazing Thin Man. He looks like a skeleton, and honestly, he looks very confused.
That's topiramate. It works on both sodium and GABA. The side effects are very distinct. Significant weight loss, hence the thin man.
And cognitive slowing. He looks like he forgot his own name.
In the medical world, we sometimes jokingly call it Dopamax.
Dopamax.
Yeah, because it can make patients feel a bit dopey, struggling to find words.
And finally, booth 3. There's a man operating a very clean high-tech machine labeled SV2A.
This is levetiracetam. This is the modern favorite. It has a completely different mechanism. It doesn't touch the ion channels directly. It binds to a protein on the synaptic vesicle called SV2A.
And why is the operator so clean-looking?
Because it has a very clean profile. It has almost no drug interactions. Unlike the classic CAR, carbamazepine, which messes with all the liver enzymes, levetiracetam just plays nice with other drugs.
It's very easy to use.
Very easy to use.
No. That sounds like a winner for modern medicine. Okay, we have one scary scenario left to cover. What happens if the bull just won't stop bucking? Now, coming to the next slide.
This is the status epilepticus protocol. We are inside the medical tent now.
The definition on the wall says, seizure lasting more than 5 minutes.
That is a true medical emergency. If a seizure lasts that long, the brain is essentially frying. You need to act fast, and there is a strict order of operations.
I see a ladder with 4 steps. Step 1 is a syringe.
Step 1, stop the seizure right now. We use an IV benzodiazepine, usually lorazepam or diazepam, remember GABA. We need to flood the system with GABA to calm that storm instantly.
Okay, so that's first. What's step 2?
Step 2, prevent recurrence. The benzo works fast, but it also wears off fast, so we need a long-term stabilizer. We give IV phenytoin or phosphenytoin to lock those sodium gates with the ball and chain.
And if it's still going, step 3.
Step 3 is for refractory seizures. If the first 2 fail, we bring out the heavy hitter, IV phenobarbital, the barber. We force those channels open to shut the brain down.
And step 4 looks like a gas mask.
That's the last resort. General anesthesia, propofol or midazolam. At this point, you have to intubate the patient and put them completely under to save their neurons.
So, benzo first, then phenytoin, then phenobarb, then anesthesia. A strict order.
Always. You never skip steps on that ladder.
Okay, we've survived the tour. Let's head to the exit and look at the summary board. Now coming to the next slide.
This is our Neurotown summary board. Let's just connect the dots one last time.
Okay, I see the pictures pinned up. First, the bartender.
Zero order kinetics. Alcohol is eliminated at a constant rate no matter the concentration.
The tea party.
That's ethosuxamide. It sucks up tea currents. And it's only for absent seizures.
The tow truck driver. Oh, wait, we didn't meet him, but he looks like the guy from the protocol slide.
That's Phenytoin. He works just like the classic CAR, carbamazepine, by stabilizing that inactive now plus gate. He's the heavy lifter for status epilepticus because he can be given IV.
I see. And finally, the chef.
Valproate, the broad spectrum guy, blocks everything, treats everything, but you have to watch out for the liver, the weight gain, and especially the pregnancy risks.
This map makes it so much easier. But before we let our listeners go, we did promise some big questions to test their knowledge of Neurotown.
All right, let's see if they were paying attention.
Question 1. If a patient comes into the ER saying their vision looks like a snowfield, what did they drink and what is the antidote?
Okay, think about the lumberjack in the snow. They drank methanol. The antidote is foampizole to block the enzyme factory or ethanol to distract it.
Question 2. Which drug acts like a classic car revving its own engine, speeding up its own metabolism over time?
That's the one with autoinduction. That's carbamazepine.
Question 3. What is the key difference between how benzos and barbiturates affect the GABA channel? Think of the showgirl versus the barber.
Benzos increase the frequency of channel opening. Barbiturates increase the duration of channel opening.
Last one, and it's an important one. A pregnant woman needs seizure control. Which chef should she absolutely avoid?
She must avoid Valproate. The risk of neural tube defects, like spina bifida, is just far too high.
There you have it. We've traveled from the liver's distillery all the way to the brain's electric rodeo.
And if there is one thing to take away from all this, it's the mechanism. Whether it's the ball and chain on the sodium gate or, the ball and chain of side effects, understanding how these drugs work makes remembering them so much easier.
Absolutely. And here's a final thought for you to chew on. We talked about the broad-spectrum chef, Valproate, and the clean machine, levetiracetam.
Right. And it raises the question, why do we still use the dirty drugs, why use Valproate with all its weight gain and liver risks when we have these cleaner options?
It's a great question.
And it really comes down to effectiveness. Sometimes that old messy chef is the only one who can cook the meal right. In very difficult epilepsy, efficacy sometimes has to trump the side effect profile. It's a balance every doctor has to weigh with every patient.
Something to think about. Thank you for visiting Neurotown with us today. Keep this map in your head the next time you're studying pharmacology.
Safe travels.
See you next time on The Deep Dive.
Welcome back to the Deep Dive. Today, we're doing something a little different.
I think a little different is an understatement.
Yeah, probably.
Uh-huh.
Usually we're sifting through stacks of dry academic papers or, analyzing some new tech trend from a distance. But today we're going on a trip.
We certainly are. But I have to warn everyone, right at the top, pack your bags carefully. This isn't your typical all-inclusive holiday.
No, it is not. We are virtually visiting a place that is, well, it's imaginary, incredibly luxurious, seductive, and frankly, one of the most dangerous places on Earth.
It sounds so inviting, though.
It does. We're checking into the Opiatal Resort and Spa.
Opiatal. See, it just rolls off the tongue. But this resort is actually an elaborate mental model. It's a structural metaphor designed to help us understand opioids, the most powerful and you could argue the most double-edged pain relievers known to humanity.
And I'm ready to be the tour guide. I've gone through the brochures, which are actually the pharmacology slides you provided, and I'm fascinated by the amenities. I'm seeing pools, lounges, high-tech trams, but I'm also seeing a lot of warning signs. A lot of them.
And that's where I come in. Think of me as the resort's structural engineer or maybe the health and safety inspector. Because while the architecture of this place is beautiful and the way these drugs fit into our biology is, it's elegant, there is some very serious, very lethal chemistry holding the building up.
So our mission is pretty simple then. We're going to walk through the resort, room by room. We'll look at the guests, the different drugs like morphine, fentanyl, and codeine, and we'll explain exactly what they're doing to the furniture, which is, well, it's our brains.
Precisely. We'll start with the basics, where this place even comes from, and by the time we check out, we'll be deep into advanced receptor pharmacology. We really need to understand not just what happens, but why it happens at a cellular level.
I've got my room key. I'm ready. Let's head to the front gates.
Lead the way.
Okay. So now coming to the next slide, we are standing at the grand entrance. And it really is grand. It's this massive white marble gate, very classical Greek architecture.
Very impressive.
Carved right into the stone, it says, the Opiatal Resort and Spa. But honestly, the first thing you notice isn't the stone, it's the landscaping. It is absolutely covered in these vibrant red flowers.
A very specific flower. That is the Papaver somniferum.
The opium poppy. Papaver somniferum. It sounds like a Harry Potter spell.
It does, doesn't it? But the Latin roughly translates to the sleep-bringing poppy. And this single plant is the foundation of the entire resort. Everything we are about to discuss, every pill and patch in modern medicine regarding opioids, it all starts with the juice of this one flower.
It's wild to think that such a complex and, controversial area of medicine comes from scratching a flower bulb.
It really is. You scratch the unripe seed capsule of the poppy and this milky latex oozes out. That latex then dries into raw opium. And it's not just one chemical, it's a cocktail containing over 20 different distinct alkaloids.
And looking at the guest list posted here on the gate, we can actually see how we classify these drugs based on their relationship to that flower. It seems we have, 3 distinct tiers of VIPs staying here.
We do. It's a hierarchy based on origin. It's all about how close you are to the original plant.
Okay, so the first group is on this rustic wooden sign labeled natural alkaloids.
Think of these as the legacy guests, the originals. In pharmacology, when we say natural alkaloids, we mean substances that you can extract directly from that poppy juice without needing to perform any chemistry on them. They're, nature-made.
And the headliners here are morphine and codeine.
Exactly. Morphine is the king. It makes up about 10% of that opium juice, so it's the main active ingredient. Codeine is his slightly weaker sibling, present in smaller amounts. But they are both chemically present in the plant itself. Nature built them.
Okay, so moving past the rustic sign, we have these fancy renovated cabanas labeled semi-synthetic.
Semi-synthetic is a great term. Think of these as the legacy guests who have had a little bit of cosmetic surgery.
I like that.
We take the natural morphine molecule, which is perfect in its own right, and we tweak it in a lab. We modify the chemical structure just slightly to change its personality, maybe to make it stronger or to make it cross into the brain faster.
So it's nature, plus a little bit of lab science. And the list here is heavy. Heroin, fulcodine, hydromorphone, oxymorphone.
And heroin is the classic example of this.
No.
Heroin is just morphine that has been dressed up with two little chemical groups, acetyl groups. So its scientific name is diacetylmorphine.
And that small change does what, exactly?
That tiny chemical change makes it much more lipid soluble.
Lipid soluble means it dissolves in fat.
Yes, and your brain is guarded by a very fatty barrier, the blood-brain barrier. Because heroin dissolves in fat so well, it rushes across that barrier much, much faster than morphine can. That's why the rush is so intense and immediate. It's a semi-synthetic modification purely for speed of entry.
That makes perfect sense. Now, on the far right of the property, looking very modern, lots of chrome, blue neon lights, we have the synthetic wing.
This is the high-tech section. These drugs are synthetic, meaning they are completely man-made from scratch in a laboratory. They don't start with the poppy plant at all.
So no flower juice involved?
None. We basically looked at the shape of the morphine molecule, saw how it fit into the body's receptors like a key in a lock, and then we built brand new, totally different keys in a lab that just happen to fit the same lock.
And the roster here is intimidating. Fentanyl, methadone, pethidine, tramadol.
A powerhouse lineup, really. Fentanyl is the ninja of the group, which we'll definitely get to. Methadone is the marathon runner. These are the heavy hitters of modern medicine, and they owe nothing to the flower directly, only to the blueprint it provided us.
Before we go inside, I have to ask about this small service entrance off to the side. It says staff only. And listed there are names like papaverine and noscapine. There's a big no swimming sign with a red line through a swimmer. What's that about?
Ugh. This is a distinction that trips up a lot of students. Papaverine and noscapine are technically guests of the plant. They are alkaloids found in opium, just like morphine. However, they are not opioids in the functional sense.
Meaning they don't work for pain?
Zero analgesic activity. Not a bit. They don't touch the opioid receptors we're about to discuss. Papaverine is a smooth muscle relaxant. Noscapine is used as a cough suppressant in some places, but they do not stop pain.
So in our resort metaphor, the pool is pain relief.
Exactly. If you aren't an analgesic, if you can't relieve pain, you are not allowed in the pool. These guys work at the resort. You could say they share the DNA of the plant, but they don't get to swim.
Got it. Just because you're in the poppy doesn't mean you're a painkiller. Okay, that's clear. Let's head inside and check in.
Let's do it. Welcome to the cellular level.
Now coming to the next slide, we are entering the cellular lobby.
This is it. This is where the magic happens. This is the mechanism of action.
It's quite the lobby. Very grand blue ceilings. And standing right in the center, looking very official in a blue polo shirt, is the general manager. His name tag says Mr. G.
Mr. G is the most important person in this entire metaphor. He represents the G protein-coupled receptor.
GI.
Correct. The I stands for inhibitory. This is the lock that all the opioid keys are trying to fit into. When you take an opioid, whether it's morphine or fentanyl, it floats through your blood and binds to this receptor on the surface of your nerve cells. It shakes hands with Mr. G.
And Mr. G, he runs a tight ship.
A very specific kind of establishment. His one and only goal is to calm everything down. He is an inhibitor. He wants peace and quiet in his lobby.
I see him standing next to a light switch on the wall, look like a dimmer switch.
That's his primary administrative function. When an opioid activates Mr. G, his first action is to inhibit an enzyme called adenylyl cyclase.
Okay, let's break that down. What does adenylyl cyclase actually do in a cell?
Normally, it's the engine that produces a crucial signaling molecule for the cell, something called CAMP, or cyclic AMP. Think of CAMP-MP as the electricity keeping the lights bright and the party going inside the cell. It gets the neuron all amped up and ready to send a message.
So when Mr. G inhibits that enzyme, he's literally dimming the lights.
He's dimming the lights. He slashes the levels of CAMP-PP, which lowers the metabolic energy of the neuron. The cell becomes sluggish, less excitable. But Mr. G doesn't stop there. He has orders for the front desk and the lounge. Look at the front desk. This represents the presynaptic membrane.
The sending end of the nerve cell.
Exactly. This is where the pain signal is trying to get out and be sent to the next cell.
I see a delivery truck parked outside. It's a big white milk truck labeled calcium. But Mr. G is standing there, holding up a hand, blocking it from docking.
This is absolutely critical. In a nerve cell, when a pain signal comes down the line, the cell needs calcium to rush inside. Calcium is the key that unlocks the door to release neurotransmitters.
Neurotransmitters like glutamate, the ones that basically scream pain to the next cell in line.
Precisely. No calcium, no release. By blocking the calcium channels at the presynaptic desk, Mr. G ensures the pain message is trapped inside the first cell. It never even gets sent.
Wow. Okay, so that's the front desk. What about the lounge area? I see some guests relaxing on sofas. This must represent the postsynaptic membrane, the cell receiving the message.
Correct. Here, Mr. G does something different. Instead of blocking something from coming in, he opens a door to kick something out. See that guy throwing bananas out the window?
I do. He's just chucking them into the ocean. I assume bananas represent potassium because of the chemical symbol K.
You assume correctly. This represents the efflux of the potassium. Mr. G opens the potassium channels and kicks positive charge out of the cell.
Okay, so if the cell is losing all these positive potassium ions, the electrical charge inside the cell must drop, right? It becomes more negative.
It becomes very negative. We call that hyperpolarization. The neuron becomes less likely to fire.
The screen on the wall says voltage, hyperpolarized.
Think of a neuron like a loaded gun. To fire, it needs to be positively charged and ready. By kicking out all that positive potassium, Mr. G unloads the gun and puts the safety on. The cell becomes so deeply negative, so asleep, that even if a pain signal did manage to get sent from the other side, this cell is too sleepy to notice or pass it on.
That is an incredibly efficient system. Let's see if I can recap Mr. G's management style. 1. Dim the lights by lowering Canon P.
Check.
2. Block the calcium truck so the pain message can't leave the sender.
Check.
And 3. Throw out the potassium so the receiving cell is too sleepy to listen.
You've got it. And the result of those 3 actions is silence. Pain impulses are blocked at the spinal level and all the way up in the brain. It is total neural inhibition.
I can see why he's the manager. All right, we've checked in. The science is making sense. Now, coming to the next slide, let's pick where we are going to sit.
This is slide 3, the receptor lounges. Time to choose your vacation vibe.
It looks like there are 3 main distinct areas or decks where guests can hang out.
These represent the 3 main families of opioid receptors in your body, mu, kappa, and delta. Depending on which deck a specific drug prefers to sit on, you get a completely different experience.
Let's start with the biggest, most crowded one on the left. The sign says the mu deck. That's the Greek letter mu.
The mu deck is the main attraction. It's the party deck. When we talk about morphine, heroin, fentanyl, the drugs that people think of for powerful pain relief and, unfortunately, for abuse, they are all obsessed with the mu deck. They are mu agonists.
The sign lists the amenities here: analgesia, pain relief, and euphoria, which sounds great. But then there's the fine print: respiratory depression, meiosis, and reduced GI motility.
That is the deal you make with the mu receptor. It's a package deal, and you can't pick and choose. If you sit here, you feel no pain, you feel incredibly happy. That's the euphoria, the high. But the cost is paid by your body's autonomic systems. This is where your breathing drive gets turned off.
Which is the most dangerous part.
By far. This is also where your pupils shrink to pinpoints, which we call meiosis. And this is where your gut stops moving, leading to constipation.
So it's the best party, but it has the highest mortality rate.
Essentially, it's the gold standard for pain relief, but it's also the gold standard for danger.
Okay, now let's contrast that with the area in the middle. It's a much smaller, kind of shadowy section called the kappa corner. The sign says analgesia, sure, but also dysphoria and psychotomimetic effects.
You generally want to avoid the kappa corner. It's not a fun place to be.
The guy standing there looks terrified. He's staring at empty space like he's seeing a ghost.
That's the psychotomimetic part. It literally means mimicking psychosis. Drugs that activate the kappa receptor do stop pain. Mechanically, they work for spinal analgesia, but instead of euphoria, they cause dysphoria.
What exactly is dysphoria? Is it just sadness?
It's more than sadness. It's a profound sense of unease, anxiety, feeling just plain wrong in your own skin. It can come with hallucinations, paranoia, and a detachment from reality. It's a bad trip built directly into the pharmacology.
Why would nature even invent that? What's the point of a receptor like that?
That's a fantastic question. Evolution works in mysterious ways. It might be a feedback mechanism to stop an overload of our own natural endorphins, or it could be involved in stress responses, but clinically it means we have to be very careful. We don't want to design drugs that hit this receptor too hard, or the patient will be pain-free but absolutely miserable and terrified.
That makes sense. And finally, the third one, way out on the water, the delta dock.
The delta receptor is a bit more obscure, a bit more academic at this point. It provides spinal analgesia, but you'll note the warning sign on the dock. proconvulsant.
Meaning it can cause seizures.
It can. Activating the delta receptor too strongly can lower the seizure threshold and trigger seizure activity. So, in modern drug development, we mostly focus on designing drugs that can selectively target the mu receptor to get the powerful pain relief, while trying to engineer out some of the dangerous side effects.
It really is a balancing act. You want the powerful pain relief of mu, but you don't want the breathing to stop. You definitely want to avoid the ghosts at kappa and the seizures at delta.
That is the holy grail of opioid pharmacology. And most of our famous opioids, like morphine, are primarily mu agonists. They make a beeline straight for that first, most popular deck.
Speaking of morphine, I think I see him. Now, coming to the next slide, let's meet the most famous guest at the resort.
Ah, yes. Slide 4. The main character has arrived.
Here he is, a guy dressed like a Greek god lounging on a sofa. The caption calls him Morpheus.
Very appropriately named. The drug morphine was named after Morpheus, the Greek god of dreams. In pharmacology, he is the prototype opioid.
Prototype meaning he's the yardstick, the one everyone is compared to.
The universal standard. Every other pain drug in this class is measured against him. We don't say a drug is just strong. We say it is 10 times the potency of morphine or half the potency of morphine. He is the anchor for the entire class.
He's holding a big golden shield. I see lightning bolts hitting it, but they aren't getting through. The shield is labeled visceral pain.
This is a key clinical distinction. Morphine is exceptionally good at blocking visceral pain. This isn't the sharp, localized pain of a paper cut. This is the dull, deep, aching, poorly localized pain from your internal organs.
Like from a kidney stone or a heart attack or post-surgical gut pain.
Exactly those things. It's a type of pain that's very hard to treat with other drugs like ibuprofen.
The text next to him says he relieves total pain. That sounds almost spiritual.
It's a beautiful concept, actually, and it's clinically very real. Total pain means he doesn't just stop the raw sensation of ouch. He also removes the emotional components, the anxiety, the fear, the dread, and the general suffering that comes along with severe pain.
So you might still be able to tell the pain is there, somewhere in the background, but you just don't care about it anymore.
That's a perfect way to put it. You become emotionally detached from it. That is the euphoria and sedation from the mu receptor working together. It fundamentally changes your relationship to the pain.
He also has a little dog next to him on the sofa. The dog is barking, but Morpheus is shushing it. The text says, cough suppression, antitussive.
Yes, this is a central effect. Opioids act directly on the cough center in the medulla of the brainstem. They turn off the reflex and the urge to cough. That's why codeine, morphine's little brother, is so famous for being in cough syrup. It's an antitussive.
But, hang on, looking closer at Morpheus, he's not looking so good. He's holding a bucket. He looks a little green in the face.
Ah, yes, the villain of the story, nausea and vomiting. Morphine directly stimulates the CTZ, the chemoreceptor trigger zone in the brain.
That sounds like a button you do not want to push.
Yeah. The CTZ is basically the brain's vomit button. It sits just outside the blood-brain barrier, and its job is to sniff the blood for potential toxins. For some reason, it interprets morphine as a toxin and sends a powerful signal to the vomiting center. It is very, very common. You give a patient a shot of morphine to help their pain, and 5 minutes later, they are throwing up into a basin.
So he shields you from pain, calms your cough, but might make you toss your lunch.
It's the price of admission for many people, especially with the first few doses.
Well, speaking of prices, things are about to get a little darker. Now, coming to the next slide, we need to visit the pool, but I'm told to watch out for the lifeguard.
Slide 5, the danger zone. This is where we discuss the most lethal effects. This is quite simply why people die from these drugs.
We're at the pool. The water is blue, but it's full of bubbles labeled CO2, and there is a body floating face down in the water. It's a grim image.
This represents respiratory depression, the #1 cause of death in opioid overdose.
Walk us through the mechanism here. Why exactly does the breathing stop?
Okay, so normally your brain is exquisitely sensitive to carbon dioxide, CO2. If you hold your breath right now, CO2 builds up in your blood. Your brainstem has sensors that taste that CO2 and they scream, breathe! It's an overwhelmingly powerful survival reflex.
Right. You can't just decide to hold your breath until you die. Your brain won't let you.
Exactly. But morphine acts directly on that respiratory center in the brainstem, and it profoundly blunts that sensitivity. It basically puts earmuffs on the brain's CO2 sensors. It says, hey, don't worry about all the CO2 building up. It's fine. Just relax.
So the CO2 builds up to toxic acidic levels, but the brain just Doesn't care. Doesn't
Right.
send the signal to breathe.
The drive to breathe just fades away. The person breathes slower and more shallowly
Yeah.
and slower until they stop. Apnea. That is the mechanism of death. It's not a heart attack. It's just forgetting to breathe.
That's terrifying. Now, what about the lifeguard? He's looking through a telescope, but the image is zoomed in on an eye. It says meiosis, pinpoint pupils.
The lifeguard represents the key diagnostic sign. Morphine stimulates a part of the brain called the Edinger-Westphal nucleus. That's a fancy name for the part of the oculomotor nerve that controls the iris. This stimulation causes the pupils to constrict down to tiny pinpoints.
Like the head of a pin.
Exactly. If you are an EMT or an ER doctor and you find a patient who is unconscious and you shine a light in their eyes and see pinpoint pupils, you should immediately suspect opioid poisoning. It is the single most important physical hallmark. The lifeguard is watching the eyes because the eyes tell the story.
There's also a floaty in the pool with a baby on it, but there's a big red prohibited sign over it saying no neonates.
This is a strict rule. You must be extremely careful giving opioids to newborns or even to a mother during labor.
Is it just because they're so small and the dose would be too high?
It's more than that. It's anatomy. Babies have an immature blood-brain barrier. Their brain isn't fully walled off and protected from the bloodstream yet. So if you give morphine, it crosses into their brain much more easily and in much higher concentrations than it would in an adult.
So what would be a safe therapeutic dose for an adult could be a lethal dose for a baby, stopping their breathing instantly.
Correct. Their respiratory centers are exquisitely sensitive, hence no neonates at the pool.
Okay, let's step away from the scary pool and try to relax in the sauna. Now, coming to the next slide, let's go to the sauna to relax. Or maybe not.
Slide 6, the spa. And another set of unique side effects.
It's steamy in here, but the guy on the bench isn't relaxing. He is scratching his arm like crazy. He's covered in red splotches.
That represents histamine release. Morphine, more than many other opioids, has a tendency to destabilize mast cells. Mast cells are little bags of inflammatory chemicals in your immune system, and when morphine touches them, they burst open and dump histamine into your bloodstream.
Histamine is the main allergy chemical, right? It's what antihistamines block.
Yes, and it causes intense itching, we call that pruritus, as well as redness and flushing of the skin. It can make the patient look like they are having an allergic reaction, even if they aren't truly allergic to the drug's chemical structure itself. It's a direct pharmacological effect.
I see a blood pressure cuff on his arm, and the monitor is reading low U.
That's the vasodilation. Histamine is a powerful vasodilator, meaning it widens your blood vessels. When the pipes get wider, the pressure inside them drops. This causes hypotension. It's especially bad if you stand up too fast. That's orthostatic hypotension. You could feel dizzy or even faint.
There's a big warning sign on the wall of the sauna, contraindicated in asthma.
This is absolutely vital. Histamine doesn't just make you itch and drop your blood pressure. It also causes bronchoconstriction. It tightens the smooth muscle in the airways of your lungs.
So if you already have asthma where your airways are already twitchy and inflamed.
Giving morphine could trigger a severe, life-threatening asthma attack. It acts like a match in a powder keg. So a key rule in medicine: morphine is absolutely contraindicated in a patient having an acute bronchial asthma attack. You just do not give it.
That seems like a board exam question waiting to happen. Asthmatic patient in severe pain, what do you not give them?
And morphine is the answer you're looking for.
Now look at the heart monitor in the corner. It shows a slow, steady line. The screen says bradycardia.
This is interesting. Most things that lower your blood pressure, like histamine, make the heart race to compensate. That's called tachycardia. But morphine has another effect. It stimulates the vagal center in the brain,
The vagus nerve.
the brake pedal of the heart. So morphine actually slows the heart rate down, bradycardia. It's a very unique combination of effects: low blood pressure and a slow heart rate.
Okay, my brain is full.
Yeah.
Let's move on to something less glamorous, the plumbing. Now coming to the next slide, we have to talk about the resort's plumbing.
Slide 7. The GI and biliary effects. You cannot talk about opioids without talking about constipation.
The visual here is, well, it's a clogged pipe full of blocks. It gets the point across.
Opioid-induced constipation is a universal side effect. It's not a maybe, it's a when. If you take these drugs long enough, you will get it, and it can be extremely severe.
How do they clog the pipes? Is it just that the muscles of the gut get weak and lazy?
No, and this is the interesting paradox. Opioids actually increase the tone of the smooth muscle in the gut. They make the intestines squeeze down tight. But and this is the key, they completely stop the coordinated forward-moving propulsive waves, which is called peristalsis.
So the muscle is clenching really hard, but it's not pushing anything forward. It's just a static squeeze.
Exactly. It's like a traffic jam where everyone is honking their horn, but no one is moving. The longer the stool sits there, the more water is absorbed out of it, and the harder and more difficult to pass it becomes.
But the text says there's a silver lining here.
Yes. Sometimes we want to stop the gut. If you have severe debilitating diarrhea, we can use this side effect to our advantage. We can use an opioid like loperamide.
Wait, I know loperamide, that's Imodium. I had no idea that was an opioid.
It is. It's a full-on mu agonist, but it was brilliantly designed so that it does not cross the blood-brain barrier. So it works on all the mu receptors in your gut to stop the diarrhea cold, but it never gets to your brain to cause euphoria or respiratory depression. It's a fantastic pharmacological trick.
That is really smart. Now look at the water pump over there. It's labeled gallbladder and sphincter of Oddi. The pressure gauge is way in the red high G8 zone.
The sphincter of Oddi is the little muscular valve that lets bile and pancreatic juices flow from the gallbladder and pancreas into the gut to help with digestion. Morphine causes this sphincter to spasm and clamp down shut.
So the bile can't get it. It's all backing up.
Right. The pressure builds up behind that closed door. So if a patient has biliary colic, which is pain caused by a gallstone already blocking that shuck, morphine might actually make the internal pressure and the pain even worse because it spasms that sphincter.
So you're treating the pain centrally in the brain, but mechanically aggravating the cause of the pain in the gut.
You've got it. We'll discuss a better alternative for that exact situation in a minute.
And finally, the garden hose on the right, it has a knot tied in it. It's labeled urethra.
Urinary retention. It's the same principle. The sphincter of the bladder tightens up, as does the detrusor muscle. It becomes very difficult to initiate urination, especially in elderly men who might already have an enlarged prostate, making things difficult to begin with.
Constipation and can't pee. The plumbing really does take a hit.
Hmm.
Okay, let's head to the bar. I see a tram passing by. Now coming to the next slide, let's head to the bar and check out the tram.
Slide 8. We are leaving the heavy-duty morphine stuff for a moment and looking at some of the moderate opioids.
I see a juice stand called the codeine bar. The bartender is pouring a purple cough syrup.
Codeine. As we mentioned at the beginning, it's a natural alkaloid found in the plant. Its main advantages are that it has high oral availability, which is why it's so popular in pills and syrups, and it's much less potent than morphine.
The text calls it a selective cough suppressant.
That's its main claim to fame. It suppresses the cough center at doses that are generally too low to cause significant pain relief or euphoria or addiction. It's morphine-light, mostly for coughs and mild to moderate pain.
Now, driving past the bar is this trolley car, a tram, labeled Tramadol.
The Tramadol tram. This is a fascinating and, frankly, a weird drug. It's called a unique vehicle for a reason.
Why unique? What's its trick?
Because it works in two completely different ways at the same time. First, it is a weak mu agonist, just like morphine. It stops some pain that way.
Okay, that's standard.
But look at the tram driver. He's holding a butterfly net, and he's catching these happy face icons floating in the air.
The happy faces must represent serotonin,
Norepinephrine.
serotonin, 5-HT, and norepinephrine. Tramadol also works as an SNRI, a serotonin and norepinephrine reuptake inhibitor. It keeps more of these happy neurotransmitters floating around in the synaptic cleft.
That sounds exactly like how many modern antidepressant medications work.
It is. This dual action part opioid, part antidepressant, makes Tramadol uniquely excellent for treating neuropathic pain, which is nerve pain, like from shingles or diabetes. That kind of pain often doesn't respond well to pure opioids. But I see sparks flying from the tram wheels. And there's a big warning sign. Lowers seizure threshold.
That is the big danger with tramadol. Because of that excitatory effect on serotonin and norepinephrine, tramadol can cause seizures even at normal therapeutic doses in susceptible people. It's a dirty drug in that sense. It hits more than just the pain button.
There's a quick note about a drug called tapentadol here, too.
Tapentadol is tramadol's newer, cleaner cousin. It also inhibits norepinephrine reuptake, but has less of the serotonin effect, which means it causes significantly less nausea and vomiting and has a slightly lower risk of seizures. It's an upgrade.
Okay, watch out. A race car just zoomed by. Now coming to the next slide, watch out for the race car driver.
Slide 9. Meet pethidine. In the U.S., it's more commonly known as meperidine.
He's a race car driver. He looks fast.
He is. Pethidine has a very rapid onset of action, but he burns out quickly. His duration of action is short, only about 3 to 4 hours. He's a sprinter, not a marathon runner.
He's chugging a water bottle. He looks incredibly thirsty.
This is the major difference that sets him apart from morphine. Pethidine has significant anticholinergic properties. This means it blocks acetylcholine receptors, similar to the drug atropine.
And that's what causes the thirst.
Dry mouth, yes. But also, look at his heart rate monitor patch. It's beating fast. Tachycardia.
Wait a second. Morphine causes bradycardia, a slow heart rate.
Yeah.
Pethidine causes tachycardia, a fast heart rate.
Exactly. Totally opposite effects on the heart rate. Also, because of that anticholinergic atropine-like action, it rarely causes those classic pinpoint pupils. It can actually cause pupil dilation.
The text here says he is preferred for biliary colic.
Remember the plumbing, the clogged gallbladder pipe. We said morphine tightens the sphincter of Oddi. Well, pethidine has a less spasmodic effect on that sphincter because it has some smooth muscle relaxant properties from that anticholinergic effect. So if someone has intense gallbladder pain, pethidine is traditionally considered the safer choice for the pipes.
That's a huge clinical point. But look at the car's exhaust pipe. It's puffing out this black smoke labeled norpethidine. And there's a picture of a brain getting zapped with electricity.
That is the toxic metabolite. When your liver breaks down pethidine, it creates a substance called norpethidine. This stuff is not a painkiller, it's a neurotoxin. It excites the central nervous system. If it accumulates in your body, say, if you have poor kidney function or you take it for too many days, it causes tremors, twitching, and eventually seizures.
So, pethidine, good for the gallbladder, acts fast, but you absolutely cannot use it long-term or the exhaust fumes will get you.
Precisely. It's for short-term, acute use only.
Now, look into the shadows. I think I see a ninja. Now, coming to the next slide, do you see that ninja in the shadow?
Slide 10, fentanyl, the phantom potency.
He's dressed like a ninja, and he's holding a scroll that says 100x potency.
Fentanyl is terrifyingly strong. It is 100 times more potent than morphine. A tiny grain of it, literally the size of a grain of salt, can produce the same effect as a full therapeutic dose of morphine. This is why it's so dangerous on the illicit market. It's impossible to dose correctly without lab equipment.
The ninja is running through a wall of yellow blocks.
Butter?
Fat. Lipids.
What?
Fentanyl is extremely lipid soluble. It loves fat. It dissolves in fat almost instantly. This allows it to sneak through biological barriers, skin, cell membranes, the blood-brain barrier with almost zero resistance.
Is that why we have things like the fentanyl patch?
Yes, that's the clinical application of this property, transdermal patches. Because it's so lipid soluble, it can soak right through your skin and into the capillaries in a slow, controlled release. It's fantastic for long-term, stable cancer pain management because you just stick a patch on and get steady relief for 3 days.
He's also balancing on a tightrope that has a heart icon on it. This is his great redeeming quality in a hospital setting. Fentanyl maintains remarkable cardiovascular stability. Even during intense heart surgery, when the body is under extreme stress, it doesn't cause the blood pressure or heart rate to drop dangerously. It keeps things steady.
And the stopwatch in his hand says, short duration.
When given by Favre, yes, just like a ninja, in and out. It acts within a minute and wears off relatively quickly. That, combined with its cardiac stability, makes it an ideal anesthetic agent for operations.
Strong, sneaky, heart-safe, and fast. A true professional.
A dangerously effective professional.
Now let's leave the ninja and look at the road. There's a marathon runner. Now coming to the next slide, we see a marathon runner on a long road.
Slide 11. Methadone, the long recovery road.
He's jogging steadily, not sprinting like the pethidine racer. He's sipping from a juice box.
Methadone is a long-acting mu agonist, and that juice box represents its high oral bioavailability. You can drink it, and it works great, which is a huge advantage.
The text mentions substitution therapy. This is for addiction treatment, right? This is what you hear about at methadone clinics.
This is the primary use of methadone today. It is a cornerstone of treatment to help people who are dependent on heroin or other short-acting opioids to stabilize their lives.
I've always found this a little counterintuitive. How does giving someone an opioid help them recover from opioid addiction?
It's a great question. Think about the chaotic roller coaster of heroin abuse. You inject, you get a massive euphoric high, and then you crash hard into painful withdrawal just a few hours later. Your entire life becomes about chasing that high and avoiding that crash. High, low, high, low. It's impossible to hold a job or maintain relationships living like that.
Right, it's a full-time job.
It is. Now, methadone acts for 24 hours or even longer. It creates a steady state. You take one oral dose a day. There is no euphoric rush because it comes on slowly, but it occupies the opioid receptors just enough to prevent the horrible crash of withdrawal. It flattens that chaotic curve.
So the person can finally function. They aren't high, but they aren't sick and desperate either.
Exactly. It buys them the stability they need to engage in therapy and repair their life. And because the withdrawal from methadone itself is much slower and milder, though it does last longer, it allows for a very gradual, controlled taper over months or years when the person is ready.
There's a banner hanging over the road. Exchange rate, 1 milligram methadone equals 4 milligram morphine.
That's a critical warning to doctors. Methadone is very potent. And because it's so long-acting, it accumulates in the body's fatty tissues. You have to be extremely careful when starting the dosing, or it can build up to toxic, fatal levels over the first week.
It's a marathon, not a sprint, in every sense of the word.
Correct.
Now, things are getting a little weird. The doors to the room seem to be malfunctioning. Now, coming to the next slide, the doors are acting weird. We have mixed signals.
Slide 12. Partial agonists and mixed agonists-antagonists. This is where pharmacology gets really nuanced and clever.
On the left, we have a door with a ninja stuck in it. He's pulling on the handle with all his might. But the door is only opening about halfway. The ninja is labeled buprenorphine.
Buprenorphine. It is a partial mu agonist.
What does partial mean here? How can he be a partial agonist?
It means it has a very high affinity, it sticks to the mu receptor like superglue, but it has low intrinsic activity. It only turns the receptor on about halfway. It acts like a dimmer switch that you can turn up, but it stops at 50% brightness. It can never give the full 100% effect of morphine or fentanyl.
The sign says ceiling effect. Is that related?
That's exactly it.
Yeah.
Because it only opens the door halfway, there is a limit, a ceiling to how much respiratory depression it can cause. Even if you take more and more of the drug, the effect maxes out at a certain point. This makes it much, much safer in terms of overdose risk compared to a full agonist.
But the text also warns, hard to reverse with naloxone.
That's the downside of that high affinity, that super glue-like binding. Because it sticks so tightly to the receptor, if you do have an overdose and need to reverse it, it's very hard for naloxone to come in and kick it off the receptor. You need much higher doses of the antidote.
Okay, on the right, we have a guy holding a drama mask, you know, the happy and sad face. The drug is pentazocine.
Pentazocine is a mixed agent. It's a weird one. It acts as an agonist at the kappa receptor.
The bad trip receptor.
The bad trip receptor, yes. So it causes spinal analgesia, but at the same time, it acts as a weak antagonist or blocker at the mu receptor.
So it turns one receptor on and turns the other one off.
You've got it. But remember the kappa corner.
The ghosts, the dysphoria.
Right. Pentazocine is notorious for causing psychomimetic effects. Hallucinations, nightmares, a general feeling of unease.
And the heart monitor next to him is spiking upwards. Sympathetic stimulation.
Unlike morphine, which slows everything down, pentazocine raises the heart rate and blood pressure. It increases the workload of the heart, so you would never want to give it to someone having a heart attack.
So given the side effect profile, it's generally not a first choice for pain.
Generally not. There are much cleaner, more effective options available today.
Suddenly the sky is turning dark. The wind is picking up outside the resort. Now coming to the next slide, the weather is changing. A storm is coming.
Slide 13. Overdose and withdrawal, the two extreme poles of the opioid experience.
The screen is split. On the left, it's a dark, cold hospital room labeled acute poisoning, and there's a glowing blue triangle in the middle.
This is the classic triad of opioid overdose. Every medical professional and first responder has this memorized. If you see these three things together, it's opioids until proven otherwise.
Okay, let's go through them. Point 1, coma or profound unconsciousness.
Correct. The patient is unresponsive.
Point 2, pinpoint pupils, the meiosis we talked about.
Yes.
And point 3, respiratory depression or apnea. They've stopped breathing.
Correct. Coma, pinpoints, apnea. That is the triad. And there is one cure hanging on the IV pole next to the bed.
Naloxone, brand name Narcan.
Naloxone is the pure antagonist. It's the antidote. It has a higher affinity for the mu receptor than most opioids, so it comes in, kicks the opioid off the receptor, and wakes the patient up almost instantly. It's a true miracle drug.
Now look at the right side of the screen. Withdrawal. It's a storm. A guy is standing on a beach, soaked, shivering, looking absolutely miserable.
Withdrawal is the exact opposite of the drug's effect. The body has gotten used to the drug being there, so when it's suddenly gone, everything rebounds in the opposite direction. If the drug causes constipation, withdrawal causes explosive diarrhea. If the drug causes sedation, withdrawal causes severe anxiety and insomnia.
if the drug causes pinpoint pupils.
Withdrawal causes huge dilated pupils, which we call mydriasis.
He's sweating, crying from lacrimation, and his skin looks bumpy.
That's goose flesh. That's actually where the term cold turkey comes from. The skin of a person in withdrawal gets goosebumps and looks like a plucked turkey. They feel horribly cold and are shivering despite sweating.
Is withdrawal fatal?
It's very, very rarely fatal, unlike withdrawal from alcohol or benzodiazepines, which can cause lethal seizures. Opioid withdrawal just makes you wish you were dead. It feels like the worst flu of your life, times 10, but it's medically manageable.
We've survived the storm. But before we leave the resort, we need to read the fine print. Now, coming to the next slide, before we leave, we must read the house rules.
Slide 14. Contraindications and cautions. These are the situations where you should never give an opioid, or at least be extremely careful.
Rule 1. A skull with a red X over it. No head injury.
This is a tricky but vital point. As we said, opioids suppress respiration. This causes CO2 to build up in the blood. CO2 is a potent vasodilator in the brain. It makes the blood vessels in the skull swell up.
And if you have a head injury from a car crash or a fall,
You already have swelling and bleeding in the brain. The pressure inside your skull is already high. If you give morphine and swell those vessels even more, you dramatically raise the intracranial pressure, ICP. You can crush the brainstem. It can be fatal.
so head trauma plus morphine is a deadly combination. Rule 2. A question mark on a stomach. No undiagnosed abdominal pain.
This is an old but wise surgical rule. Morphine is too good at its job. If a patient comes into the ER with belly pain and you give them morphine before the surgeon has examined them, you numb them up completely. The surgeon can no longer press on their abdomen to find the point of maximum tenderness. You might miss the signs of a ruptured appendix. Diagnose first, then treat the pain.
Rule 3 is a repeat from the sauna. No acute asthma.
Correct. We've covered this one. The histamine release causes bronchoconstriction. You don't want to choke the patient.
And Rule 4, a pressure gauge on low. Caution in hypovolemia.
Hypovolemia means low blood volume, like a patient who is bleeding out or in shock. Because opioids dilate blood vessels and lower blood pressure, if you give them to a patient who is already in shock with low blood volume, their blood pressure will bottom out completely. You can precipitate a full-blown cardiovascular collapse.
Wow. We have toured the entire facility. From the poppy fields to the synthetic chemistry labs, we've met Mr. G, Morpheus the Greek god, the ninja fentanyl, and the racer pethidine. We survived the pool and the storm.
We have. It's been quite a tour, but before I let you check out, I need to make sure you are paying attention.
Oh no, a pop quiz. Is this on final?
Just a few questions to see if the key concepts from our tour stuck.
Okay, hit me with them. I'm ready.
Question 1. You are in the ER. A college student is wheeled in by their friends. They're in a coma. They're barely breathing, maybe 4 breaths a minute. And when you open their eyes, the pupils are tiny pinpoints. What is the first drug you grab?
That's the classic triad. Coma, pinpoint pupils, respiratory depression. I'm not even thinking. I'm grabbing the antidote. Naloxone given intravenously.
Correct. You saved the life. Okay, question 2. You have a 65-year-old patient who is having a heart attack. The pain is crushing. You want to give an opioid to help the pain and anxiety, which is a standard procedure. But you see in their chart that they have a long history of severe asthma. Can you give morphine?
Ooh, this is a good one. Morphine is great for the heart pain. But wait. The spa slide, the sauna. Morphine releases histamine. Histamine tightens airways. So, NO. It is absolutely dangerous for that asthmatic patient. You need to pick a different opioid, maybe fentanyl, which doesn't cause histamine release.
Excellent. You avoided the bronchoconstriction. Question 3. Why on earth do we use methadone, a potent opioid, to treat addiction to other opioids like heroin?
Because of the marathon runner. It's long-acting and orally active. It creates a steady state in the body. It stops the horrible withdrawal symptoms without giving the euphoric high, allowing the person to break the cycle of abuse and get their life back on track.
Perfect. Last one. Question 4. A patient comes in with classic biliary colic severe, cramping pain in their upper right abdomen from a gallstone. Why would a knowledgeable doctor choose pethidine, the racer, instead of morphine, the prototype?
The plumbing. It all comes back to the plumbing. Morphine tightens the sphincter of Oddi, which could increase the pressure behind the gallstone and make the pain worse. Pethidine has less of that spasmodic effect on the sphincter because of its anticholinergic properties. It's the smoother choice for the pipes.
You passed the final inspection. You've earned your checkout key.
Yes.
We have officially survived the opiate toll.
This has been an incredible deep dive. We learned that opioids are these profound double-edged swords. They offer the heaven of analgesia and euphoria at the mu deck.
And the hell of addiction, respiratory depression, and terrible withdrawal at the very same receptor sites. There's no separating the good from the bad.
They are the most powerful tools we have for treating severe pain, but they demand an incredible amount of respect.
Absolutely. Understanding the mechanism, Mr. Gee, the different receptor lounges, the unique personalities of each drug is the only way to use them safely and effectively.
Thank you so much for keeping us safe on this tour. It was fascinating. And thank you to you, the listener, for coming along on this trip with us. Keep asking questions, stay curious, and always respect the pharmacology.
See you in the next deep dive.
Looking at this first slide, the overview, I see 5 distinct characters wandering around the park. And I get the feeling that if we don't understand who they are, the rest of this tour just won't make any sense.
You are absolutely right. These are your neurotransmitters, but in Synapse City, they are the workers. They're the ones keeping the lights on.
So let's unpack this metaphor. I'm looking at the overview. It's a panoramic shot. It looks like a festival inside a skull. It really does.
Let's do it. It's the only way to understand how any of this really works.
Now coming to next slide. Okay, we are standing at the entrance. This is slide 1. Welcome to Synapse City Fairground. And wow, what a view. You can see the whole geography of the brain just mapped out as these like entertainment zones.
It's a fantastic way to orient yourself, isn't it? You've got the frontal lobe area down at the bottom left. That's your executive function, your whole decision-making center.
The park management office, maybe?
Basically, yeah. Then you've got the limbic system in the middle, which is where all the emotion happens, the fun house, the haunted house, all of that. But before we even buy a ticket, we have to talk about the gate.
Yeah, right in the center. There is this massive metal turnstile. It's huge, and it's labeled BBB.
The blood-brain barrier.
It looks tough. There are guards there. It reminds you of the security line at an airport, but way stricter.
It has to be tough. I mean, think about it. The brain is the VIP section of the body. It's the control room. And your blood is full of all kinds of junk. I mean, bacteria, viruses, toxins from that, questionable sushi you ate last night, fluctuating hormone levels. If all of that just washed into your brain freely, your neurons would be misfiring constantly.
There would be chaos.
Complete chaos. You'd be hallucinating every time you caught a common cold.
So the BBB is the bouncer.
It is the ultimate bouncer. It keeps the environment inside the park perfectly stable. It's a climate-controlled dome. It only lets in very specific things. Oxygen.
Come on in.
You're on the list. Glucose for energy. You're a VIP. Lipid-soluble molecules that can sort of sneak through the fatty membrane, sure. But most drugs, most medications we invent, the bouncer takes one look and says, "Not tonight, pal."
Which creates a huge problem for pharmacology, right?
Right?
How do you get the medicine to where it needs to go? I assume we'll get to that.
We absolutely will. It's one of the biggest challenges.
But once we do get past security, I'm seeing these characters wandering around the park. So let's introduce the staff, because these guys are absolutely everywhere. First up, who is the guy in the grease-stained overalls? He's got a wrench.
That is Dopamine. We'll call him DA for short. He is the mechanic.
A mechanic. That's interesting. I always thought of dopamine as the party guy.
Yeah.
The pleasure molecule. Sex, drugs, rock and roll.
And that's the pop culture version, and it's not wrong exactly. He absolutely handles reward and motivation. But physiologically, his day job is much more fundamental. He's the guy who oils the gears.
Oils the gears.
Think about movement. When you want to reach out and grab a coffee cup, that motion needs to be smooth. It needs to be fluid and initiated properly. If the gears are dry and rusty, they grind. They get stuck. You get rigidity.
I see.
Dopamine lubricates the neural pathways in a part of the brain called the basal ganglia to allow for that smooth, initiated motion. He fixes the friction.
So he's not just about the thrill of the ride. He makes sure the roller coaster car actually rolls down the track smoothly in the first place.
Exactly. Without him, the park grinds to a halt. But then, look at the guy standing next to him. A completely opposite energy.
Oh, yeah. The bodybuilder. Massive chest, tiny tank top. Labeled Ekshi.
Acetylcholine. The strong man. He is all about force, muscle contraction, structure. If dopamine is the grease, acetylcholine is the big lever you pull to make the heavy machinery move. He manages muscle tone.
He looks really intense, like he's flexing constantly.
He is. He provides the excitatory go signal at the neuromuscular junction, but he also has a sensitive side, believe it or not. He plays a huge role in memory and learning, which we'll see way, way later when we get to the main.
Okay, so he's not just brawn.
Not at all. But for now, just think of him as the brute force that keeps the rides standing up and the muscles firing.
Then we have someone who looks a bit more chilled out, maybe a bit moody. He's wearing a tie-dye shirt. Looks like he's adjusting some colored lights.
That's serotonin, 5-HT, chemically speaking. He's the mood technician. He isn't building the rides. He's controlling the lighting, the temperature, the background music. He sets the vibe.
The atmosphere.
Precisely. If he goes on strike, it doesn't matter if the roller coaster works perfectly from a mechanical standpoint, you're just not going to have a good time. The park becomes gray, gloomy, and depressing. He regulates affect, sleep, appetite, general well-being.
Okay, makes sense. And then I see another guy who looks like he's just buzzing with electricity. Literally, he's got sparks coming off his hair.
That's Norepinephrine, NE. He is the power generator. He drives arousal, energy, and focus. He provides the electricity that lights up the neon signs and keeps you alert on the rides. Without him, the park is dim, lethargic, you can't focus on anything.
The get-up-and-go chemical.
The get up and go. And finally, there's a guy in a bright yellow high-visibility safety vest holding a clipboard and a stopwatch. That is GABA, our safety inspector. His job is inhibition and calm. He's the one walking around saying, whoa, slow down there. Keep your hands and feet inside the vehicle at all times. Stop running.
Yeah.
The lifesaver. If you didn't have a safety inspector, the power generator would overload the system, the strongman would go wild, and the whole park would burn down in a seizure. GABA is the brake pedal. He keeps things from going too fast, from getting out of control.
Okay, so we have the mechanic, the strongman, the mood tech, the generator, and the safety inspector. And the premise of this entire deep dive and this whole visual guide is that mental illness is just a labor dispute, a staffing problem.
Essentially, yes. Pathology occurs when these workers are out of balance. Look at the little notes on the side of the entrance sign. It spells it out. It says Parkinson's, low DA versus high H.
So the mechanic is missing and the strongman is taking over, running wild.
Exactly. And when the strongman runs things without the mechanic's finesse to smooth things out, you get rigidity and tremor. Then you see psychosis, high DA in the limbic zone.
Too much mechanic.
Too much mechanic tinkering in the Hall of Mirrors. It distorts reality. You start seeing and hearing things that aren't there.
And depression, low 5-HT and NE.
The mood tech and the power generator are both offline. The park is dark, sad, and you have no energy to even get out of bed.
This is such a clear way to visualize it. I mean, it's brilliant. I'm ready to see the specific zones now. Let's go ahead to our first attraction.
Lead the way. I think you'll find it illustrative.
Now, coming to next slide. All right, we walked over to the left side of the park and yikes. This ride has definitely seen better days. We are looking at slide 2, the rusty wheel.
This is our metaphor for Parkinson's pathology.
It's a Ferris wheel and it's labeled substantia nigra, but it is just falling apart. It's rusted through. There are cobwebs everywhere, and the operator booth looks completely abandoned.
The substantia nigra is a specific part of the midbrain. Its name literally means black substance, and it's the factory that produces dopamine. In Parkinson's disease, the dopaminergic neurons in this area, the mechanics, degenerate and bang off.
So that's why the booth is empty.
The factory is closed, the workers are gone, and because the factory that produces the grease is shut down, the structure starts to rot away.
And because the structure is rotting, the ride is malfunctioning. The slide highlights 4 key symptoms, and they're hidden in the picture like Where's Waldo puzzle. Let's hunt for them. First, I see a snail, a single snail, crawling very slowly on one of the wheel spokes.
The snail, that represents bradykinesia?
Bradykinesia, that sounds technical.
Back it down, brady means slow, and kinesia means movement. So slow movement. But it's more than just being slow. Patients with Parkinson's have a terrible time initiating movement.
It's the startup that's the problem.
Exactly. It's not just that they are slow runners. It's that the signal from the brain to go is moving at a snail's pace. You tell your hand to lift the cup, and there's this lag, a hesitation. It's like the message gets stuck in traffic.
Got it. Okay, next, I see our friend the strongman, Hatish, but he looks angry. He's wearing a prison uniform, a black and white striped suit, and he is literally gripping the gears of the Ferris wheel, preventing them from turning.
That represents rigidity, specifically something we call cogwheel rigidity. Remember, the mechanic, dopamine, isn't there to grease the gears and provide that smooth inhibitory control.
Right.
So the acetylcholine strongman goes completely unchecked. He cranks up the muscle tone everywhere. He's just tensing everything.
So he's over-tightening all the bolts on the ride.
Exactly. And when a doctor tries to move a Parkinson's patient's arm, it doesn't move smoothly like a well-oiled hinge. It ratchets. It goes click, click, click.
Like a cogwheel.
It feels just like a cogwheel because the muscles are fighting the movement every step of the way. The strong man is holding on way too tight.
That's a really visceral image.
Yeah.
Then I see sparks flying near the central axle of the wheel, and the whole wheel itself seems to be vibrating or shaking.
That's the tremor, the classic pill-rolling tremor at rest. It's called that because it often looks like the person is rolling a small pill between their thumb and forefinger.
And it happens at rest, so when they're not trying to do anything.
Correct. It's often worse when the limb is relaxed and actually gets better when they try to perform an action. It's a very distinctive sign.
And finally, the whole structure just looks like it's about to tip over. One of the main support legs is buckled. It looks really unstable.
Postural instability, loss of balance. As the disease progresses, these patients fall very easily. Their center of gravity is off. So you have the 4 cardinal signs of Parkinson's right there in one image. Bradykinesia, the snail. Rigidity, the strong man. Tremor, the shaking whale. And postural instability, the buckled leg.
It's all there. And there's a scale in the foreground of the picture that really just sums this all up. It's a classic balance scale. On the left side, there's a little plate labeled DA for dopamine, and it's completely empty. It's way up in the air.
Right, the light side, there's nothing on it.
And on the right side, the plate labeled ATA is piled high with these heavy iron weights, and it's crashed all the way down to the ground.
And that is the fundamental neurochemical imbalance of Parkinson's disease. It's a seesaw that's stuck. You have a profound deficiency of dopamine, which leads to a relative overactivity of acetylcholine.
What do you mean relative?
It's not necessarily that you have more acetylcholine than a healthy person. It's that you don't have the dopamine to balance it out. The strong man hasn't gotten stronger. The mechanic has just disappeared. So now the strong man runs the show unopposed.
So looking at this broken ride, the goal for any treatment seems pretty obvious. We need to balance that scale.
Correct. We have 2 main strategic choices here. We can either try to put more weights on the dopamine side, that is, restore the DA, or we can try to take some weights off the acetylcholine side, inhibit the AC.
Simple enough in principle. Let's try to add some dopamine. Just hire more mechanics. But wait, we already established the security problem. That bouncer, the BBB.
We did. And that brings us to what I like to call the greatest heist in pharmacological history.
Now coming to next slide. Okay, we are back at the main entrance gate, the BBB turnstile. This is slide 3, the rope import. And it looks like we have a serious logistical puzzle to solve.
We do. As we said, we need to get dopamine into the park to fix the rusty wheel. But dopamine itself, the finished product, cannot cross the BBB. The bouncer stops him cold.
So what do? I'm seeing a delivery truck labeled dietary amino acids backing up to the gate. And inside that truck, there are these big, thick coils of rope, and they're all shaped like the letter L.
The rope is levodopa, or L-dopa for short. It is the chemical precursor to dopamine.
It's the raw material.
It's the raw material. And look at the turnstile. The rope fits through. L-dopa can cross the BBB. It's an amino acid, so it gets a special pass. It uses a specific transport system, the amino acid transporter, to get inside.
So the strategy is don't ship the finished mechanic, ship the raw materials, and let the brain build the mechanic on site.
That's a perfect analogy. It's like shipping a flat-pack piece of furniture from IKEA because the fully assembled chair won't fit through your front door.
I get that. But of course there's a problem. There's a villain.
There is always a villain. I see him. He's standing outside the gate, kind of lurking in the parking lot. He's wearing a striped shirt and a mask. He's holding a giant pair of scissors, and he's labeled peripheral decarboxylase.
Peripheral, meaning outside the center, outside the brain.
Exactly. This is an enzyme that hangs out in the blood and the body tissues, the periphery. His one job is to cut that L-dopa rope. He metabolizes it. He turns L-dopa into dopamine before it can ever get into the brain.
Wait, why is that bad? Dopamine is what we want.
We want it in the brain. If that robber cuts the rope outside the gate, you get a flood of dopamine in your body. And do you know what dopamine does in your gut and your heart?
I have no clue.
It hits a place in your brainstem called the chemoreceptor trigger zone, which is a fancy name for the vomit center. It causes massive, debilitating nausea, and it hits receptors in your heart and blood vessels, causing hypotension and arrhythmias. So if you just give a patient L-dopa by itself, they spend the whole day throwing up and feeling like they're going to faint, and only a tiny, tiny fraction of the rope actually makes it into the brain to fix the Parkinson's.
So the robber not only steals our supply, he uses it to make us sick.
Precisely, which
Yeah.
is why we need the hero.
Yes. Standing right next to the robber is a police officer. But he's weirdly shaped. He looks like a giant pill, a capsule. His name tag says Carby,
This is carbidopa.
and Carby has put handcuffs on the robber.
Carbidopa is a peripheral decarboxylase inhibitor. His only job is to handcuff that enzyme. He physically stops the robber from cutting the rope in the driveway.
But here is the detail that I find so clever, and the slide highlights it with a big red circle. Carby is standing outside the turnstile.
That is the crucial multi-million-dollar detail. Carby cannot cross the BBB. The slide says Carby stays outside. This is perfect pharmacological design.
Why is that so perfect?
Well, think about it. If Carby could get into the brain, he would stop the conversion of L-dopa to dopamine inside the brain, which would defeat the whole purpose of the mission. We need that conversion to happen inside, but not outside.
So Carby is the perfect bodyguard. He protects the rope on the dangerous streets of the body, escorts it right to the VIP entrance, and then waves goodbye at the turnstile as the rope goes through alone.
Exactly. And you can see on the other side of the gate, once it's inside the brain, the rope is glowing gold. The slide calls it the dope rope. Once inside, the brain's own enzymes turn that L-dopa into dopamine, and the mechanic is finally back on the job.
And the slide notes that Cinnamint is the brand name for the combination of the rope levodopa and the cup, carbidopa.
Right. They are almost always given together. You rarely see L-dopa prescribed without its bodyguard. It's the absolute standard of care.
That makes so much sense. It's such an elegant solution to a huge problem. Okay, we fixed the Ferris wheel, or at least we've got it moving again. But now, let's head over to the spookier side of the park. The whole mood is changing. Now coming to next slide. Whoa. Yeah, the weather just changed instantly. We are standing in front of a dilapidated, gray, Victorian mansion. There's thunder and lightning in the background. This is slide 4, the haunted house.
And this brings us to the treatment of depression, specifically an older class of drugs called the TCAs, the tricyclic antidepressants.
Why the haunted house theme? Is it just because depression is a dark place?
That's part of it, but it's also because these drugs are old, they're a bit scary, and frankly, they have some cobwebs on them. We don't use them as a first-line treatment much anymore for reasons that will become very clear.
I see. And to represent the tricyclics, we have this creepy little kid riding a tricycle right in the front yard. He looks like something out of a horror movie.
That's the tricycle gang. This represents drugs like amitriptyline, nortriptyline, imipramine. The name comes from their 3-ring chemical structure.
This kid looks malicious. He is riding his trike and he's just smashing into things. Specifically, he is smashing 2 vacuum cleaners. One vacuum is blue and labeled CERT, and the other is orange and labeled NET.
Those vacuums represent the reuptake pumps. CERT is the serotonin transporter, and NET is the norepinephrine transporter.
How does a vacuum cleaner work in the brain? What's the analogy here?
Imagine the synapse, that tiny gap between 2 neurons, is the floor of a room. To send a signal, you release neurotransmitters, our workers, onto the floor. They go and push buttons on the other side.
Okay.
But you don't want them hanging around on the floor forever. So normally these vacuums come along and suck the workers back up into the first neuron to be recycled. They clean the floor, ending the signal.
But the tricycle kid is smashing the vacuums.
Right. He is inhibiting reuptake. If you break the vacuum cleaner, the workers, serotonin, our mood tech, and norepinephrine, our power generator, stay on the floor longer. They stay in the synapse. They keep pushing the buttons on the other side.
You get more signal.
You get more signal. That's how the drug lifts depression. It boosts the signal of these crucial mood-regulating chemicals.
Okay, so smashing the vacuums is the therapeutic effect. That's what we want him to do. But this kid is a total menace. He's not just hitting the vacuums. He's crashing into everything else in the yard. It's a disaster zone.
And that is the perfect metaphor for TCAs. They are dirty drugs. They don't just hit their intended targets. They hit a bunch of other receptors too. We call this promiscuous binding or having an off-target effect. They are sloppy.
Let's look at the collateral damage here. First, in the bottom left, the kid has crashed into a giant salt shaker. It's knocked over. Salt is spilling everywhere. The label says sodium channel.
This is the most dangerous side effect by far. The salt shaker represents the cardiac sodium channels. PCAs inhibit these channels in the heart muscle.
And what happens when you block sodium channels in the heart?
Yeah.
That sounds bad.
It is very bad. The heart uses sodium channels for its electrical conduction. If you block them, you slow down that signal. On ECG, you see something called a wide QRS complex. It can lead to fatal arrhythmias. This is the major cause of death in a TCA overdose.
Ah.
The mnemonic on the slide is anti-Dep-C for cardiac. If a patient takes a whole bottle of these to end their life, which sadly happens, the heart toxicity is what kills them. It's a very dangerous tool to give to a severely suicidal patient.
That's terrifying. Yeah. What else did he hit? There's a spilled bottle of liquid next to the salt, and it's labeled Anticholinergic.
The kid crashed into the acetylcholine supplies. TCAs block muscarinic acetylcholine receptors. Remember the strongman seal. We are blocking him. This leads to the classic drying side effects.
What does that mean, drying?
Think about what ASIC does. It makes things wet and moving. Saliva, gut motility, bladder contraction. So if you block it, you get dry mouth, constipation, urinary retention, blurry vision. Everything dries up and slows down.
And then there is a man in a nice suit lying flat on his back on the ground. His briefcase is open, papers are everywhere, his hat has flown off.
That's the alpha blockade. TCAs block alpha-1 adrenergic receptors. These receptors are on your blood vessels, and they normally keep your vessels constricted just enough so you can stand up without all the blood rushing to your feet.
So they fight gravity.
They fight gravity. When you block them, your vessels stay dilated, you stand up, gravity pulls the blood out of your brain, your pressure plummets, and boom, you're the man on the ground. It's called orthostatic hypotension.
And finally, the slide just mentions H1 blockade.
Right, histamine blockade. That causes sedation, makes you sleepy, and often weight gain. So to sum it up, while the tricycle kid does a good job of keeping serotonin and norepinephrine around to help your mood, he makes a huge mess of the yard. You're sleepy, gaining weight, dizzy when you stand up, dry-mouthed, and potentially having life-threatening heart rhythm issues.
It sounds like a really rough ride. I can definitely see why we invented newer, cleaner drugs. But are there other, even older places in the park for depression?
There are, but to get there, we have to go down to the cellar. It gets darker before it gets lighter.
Now, coming to next slide. This feels completely different from the yard. We're in a dark brick wine cellar. The slide calls it the wine cellar. It's filled with crates of wine, big wheels of aged cheese, and hanging sausages and cured meats. It looks delicious, actually.
Don't eat anything. This represents slide 5. The MAO inhibitors, MAOIs, drugs like phenylzine and salicyline.
Are these the heavy hitters?
These are the old school nuclear options. We really only use them now for what we call atypical depression, when the house rides didn't work and the patient is really, really suffering.
Okay, let's look at the mechanism. On the left side of the cellar, there's a rat in a cage. The rat is labeled MAOA.
MAO stands for monoamine oxidase. In a normal brain, this enzyme acts like a rat. It eats up the monoamine neurotransmitters. It gobbles up dopamine, serotonin, and norepinephrine. It's the cleanup crew that breaks them down after they've been used.
But here the rat is locked in a cage. The cage is labeled enzyme inhibition.
Right. The drug is the cage. It's an irreversible inhibitor in many cases. It locks up the rat, and the rat can't eat the workers. So what happens? The levels of serotonin, norepinephrine, and dopamine all rise because nothing is there to destroy them.
Sounds great. Very effective. Why on earth don't we use this all the time?
We don't use it because of what is on that table. This brings us to the infamous cheese reaction.
I see the feast. Aged cheese like a cheddar or Parmesan, red wine, cured pepperoni.
All of these delicious aged foods contain a substance called tyramine. Now, usually that MAO rat lives in your gut and liver as well as your brain. When you eat a piece of cheese, the gut rat eats up all the tyramine before it can get into your bloodstream. It protects you.
We cage the rat.
Exactly. We cage the rat everywhere. In the brain, yes, but also in the gut. So now, when you're on an MAOI and you eat that fancy cheese board, the tyramine is not broken down. It gets absorbed, intact, and floods into your bloodstream.
And tyramine is bad.
Tyramine is what we call an indirect sympathomimetic. It acts like a key that unlocks the emergency reserves of norepinephrine. Look at the center of the room. There's a huge red industrial valve on a pipe, and it's labeled NE release.
And there is a massive jet of white steam just exploding out of it. The steam cloud forms the numbers 2,120.
That is a hypertensive crisis. That is a life-threatening blood pressure. The tyramine hits that valve, forces a massive release of norepinephrine into the system, and your blood pressure skyrockets. It's like a steam pipe exploding in your circulatory system. It can cause a stroke or a heart attack.
So this is not a suggestion. This is a deadly serious dietary restriction. No wine and cheese parties if you're on an MAOI.
Strictly, absolutely forbidden. It's a major lifestyle change and a huge burden for patients.
But wait, there's a ghost in the cellar. I see a glowing, translucent figure of a man holding a wrench. He's running towards the exploding pipe like he's trying to fix it. He's labeled Phantom.
That's a mnemonic. Phantom stands for phentolamine.
Phenytoin.
It's an alpha blocker. Remember the man who fell down in the last slide from the alpha blockade? This is the same mechanism, but used therapeutically as an antidote. If your blood pressure is skyrocketing because of the cheese reaction, you give phentolamine intravenously. It blocks the norepinephrine from constricting the blood vessels. It opens the system up.
It's the emergency pressure release.
It essentially uses a wrench to fix the pressure buildup before the whole system blows.
Okay, let's get out of the cellar. It's way too high pressure for me. I think I want to go find a roller coaster. I need some excitement. Now coming to next slide, and here we are. This is slide 6, the bipolar coaster. And wow, look at the track on this thing. It has these impossibly high, jagged peaks labeled mania, and then it just plummets into these deep, dark chasms labeled depression.
This is the visual for bipolar disorder. It's not just about being happy or sad, it's the oscillation. The brain swings between the poles, the high-energy, reckless, sleepless mania and the low-energy, hopeless, crushing depression. It's a ride no one wants to be on.
It looks terrifying. And riding in the coaster car, there is a giant battery. It looks like a Duracell battery, but it's labeled lithium.
Lithium. It's the classic, the original mood stabilizer. And it's fascinating because it's not some complex organic molecule designed in a lab. It's an element, a simple salt. It's number 3 on the periodic table, right under hydrogen and helium.
So how does this simple battery stabilize such a violent roller coaster?
Well, its exact mechanism is still debated, which is amazing for a drug we've used for so long. But the leading theory is depicted here. Look at the wires. The battery has jumper cables coming out of it.
Yeah.
It is clamping onto the tracks. And specifically, it is interrupting a sparking wire that runs along the track. And that wire is labeled IP3 pathway.
Inositol triphosphate.
Right. We don't need to get bogged down in the deep biochemistry, but essentially, inside the neuron, there's a whole signaling cascade involving IP3 that ramps up excitability. You can think of it as the accelerator for the coaster car.
The gas pedal.
The gas pedal. Lithium seems to cut that wire. It inhibits the IP3 pathway and other downstream targets, effectively dampening the go signal inside the cell.
So it prevents the coaster from going too high into mania.
And too low into depression. That's the amazing part. It clamps the track to the middle ground. It creates a floor and a ceiling for mood. It prevents the mania, and it also lifts the depression. And remarkably, it is one of the only psychiatric drugs that is consistently proving to reduce the risk of suicide in these patients. It's a true stabilizer.
That's incredible. But there's a big warning sign hanging over the track. It looks like a road sign for a low bridge. It says narrow clearance, 0.61.2.
That is the therapeutic index. And in lithium's case, it is incredibly, notoriously tight.
0.6 to 1.2. What are the units?
Milliequivalents per liter. It's the concentration of the drug in the blood. If you are below 0.6, the battery isn't strong enough to clamp the tracks. The coaster goes wild anyway. If you are above 1.2, well, the battery starts to leak acid.
It becomes toxic.
Highly toxic. And the window between a helpful dose and a dangerous dose is tiny. This means you have to monitor blood levels constantly. It is absolutely not a take-it-and-forget-it drug. Patients need regular blood draws to make sure they're in that very narrow sweet spot.
And what happens if the battery does leak? What does that toxicity look like? I think the next slide shows us exactly that. Now coming to the next slide.
Oh boy. Slide 7, battery leaks and backup generators. The lithium battery in the foreground is cracked wide open. This yellow, noxious-looking acid is oozing out everywhere. This is not good.
This represents lithium toxicity, and the slide gives us a classic triad of symptoms to look for. 3 big things that happen when the levels get too high.
Okay, what's first? The person who is holding the battery, their hands are shaking violently. It's not a subtle shake. That's the first sign, often. A coarse tremor. It's different from the pill-rolling tremor of Parkinson's. This is a big, shaky, coarse movement, like you've had 20 cups of coffee. It's a key indicator that the levels are creeping up.
Then there are 2 other very strange figures standing in the puddles of battery acid. First, there's a snowman. A literal snowman with a carrot nose and a top hat. He's labeled hypothyroidism.
Lithium interferes with the thyroid gland. It gets taken up by the thyroid and inhibits the release of thyroid hormone. It essentially freezes your metabolism.
Hence the snowman.
Hence the snowman. Patients can gain weight, feel cold all the time, lose their hair, get sluggish and constipated. It induces a winter in the body. It's a common long-term side effect that needs to be monitored.
And next to the snowman, there is a water fountain that is just spraying water everywhere. It's leaking from the base. The spout is going wild. It's an uncontrollable fountain.
That represents nephrogenic diabetes insipidus.
That's a mouthful.
Let's break it down. Nephrogenic means originating in the kidney. Lithium goes to the kidneys and it blocks the action of ADH antidiuretic hormone. ADH is the hormone that tells your body to hold on to water, to concentrate your urine.
So it's the anti-pee hormone.
Exactly. If you block it, your kidneys can't save water. They just dump it all. You pee a lot. Gallons.
The medical term is polyuria.
Exactly. And because you are peeing out all your body's water, you get incredibly insatiably thirsty. Polydipsia. That's why the fountain is spraying. The patient is constantly drinking and constantly urinating. It's a very distinct side effect.
Okay, so the battery is effective, but it's high maintenance, it's risky, and it makes you shake, freeze, and pee. What if you can't use it? I see some cars in the background of the slide. Backup generators.
These are the alternative mood stabilizers. And interestingly, they're mostly drugs we borrowed from the epilepsy department. They are anticonvulsants.
Okay, first, there's a colorful, almost psychedelic-looking car with a weird license plate. It says Festival Plate.
That's our mnemonic for Valproate, also known as Depakote.
Ugh, a Valproate. Festival Plate. I see what they did there. That's good.
It's a very effective mood stabilizer that works by blocking sodium channels and also by increasing GABA, our safety inspector. But notice the big warning sign on the car?
Yeah, it has a no pregnant people symbol.
Right. It's a major teratogen. It can cause serious birth defects, specifically neural tube defects like spina bifida. The spine doesn't form correctly. You absolutely cannot give this to a woman of childbearing potential without very careful consideration and contraception. It's also hard on the liver hepatotoxicity.
Got it. And next to the Festival Plate car, there is an old-fashioned antique car, a vintage model.
That is carbamazepine. Think carbamazepine, the vintage car.
The vintage car.
The key thing to remember about this car is its engine. Notice it's revving loudly. There's smoke coming out of the exhaust pipe. Carbamazepine is a potent inducer of the P450 enzyme system in the liver.
It regs up the liver. What does that mean?
It makes the liver's metabolic machinery work overtime, much faster than usual. This means it chews up other drugs you're taking much more quickly. If you are on carbamazepine, it might make your birth control pills or your blood thinners or other psychiatric meds stop working because your liver is metabolizing and eliminating them too quickly.
So it accelerates the metabolism of everything else in the garage.
That is a crucial drug interaction to remember. It's like a car that drives so fast it creates a draft that blows everyone else off the road.
Exactly. Okay, let's leave the roller coasters and the rusty cars behind. My heart rate is up from all this toxicity talk. Let's find somewhere to relax. Now, coming to next slide. This looks perfect. Slide 8. The Chill Out Lounge. It's a big, cozy tent with soft lighting and pillows everywhere.
This is our stop for anxiolytics, the drugs we use to treat anxiety.
Inside the tent, it looks like a tea house or a hookah lounge. People are lying on beanbag chairs, looking super relaxed. Some are even asleep. They're all drinking from steaming mugs labeled GABA tea.
These are the benzodiazepines, the famous ones. Drugs like diazepam, which is Valium, alprazolam, which is Xanax, lorazepam, which is Ativan.
And GABA tea implies.
They work on GABA, remember our safety inspector. These drugs don't just give him a megaphone, they give him a whole stadium sound system. They potentiate the GABA A receptor. They make the natural GABA in your brain work much, much better.
How so?
They bind to a different spot on the receptor and cause the chloride channel to open more frequently. More chloride rushes into the neuron, making it more negative inside and harder to fire.
So they basically tell the entire brain to shut up and sit down.
Yes, it's a global CNS depressant. They hyperpolarize the neurons. They make it harder for any signal to get through.
The slide notes say fast onset, deep sedation.
And that's key. If you are having a full-blown panic attack, an acute crisis where you feel like you are dying and the world is ending, this is where you go. You drink the GABA tea and boom, within minutes you are relaxed. The terror just stops.
But I see a lot of zzz bubbles coming from the people in the beanbags. They are basically all asleep.
That's the major downside, sedation. You can't drive a car safely or operate machinery. Plus, there is a huge risk of addiction and withdrawal. You can't live in the lounge forever. If you stay too long, your brain gets used to the tea.
It gets dependent.
Very dependent. And if you try to stop suddenly after long-term use, the withdrawal can be dangerous. You can even have seizures.
Okay, so that's for a crisis. What if I have chronic anxiety, like generalized anxiety disorder or GAD, where I just worry about everything every day? I can't just sleep on a beanbag all day. I have a job. I have kids.
Then you need to look outside the tent. See that yellow school bus that's slowly pulling up to the curb?
The one labeled busbarone,
Yes, we call it the slow bus.
or the slow bus.
Look at the license plate. It says 1-2 weeks.
So it takes a while to get to its destination.
A long while. Busbarone is completely different from the benzodiazepines. It doesn't touch GABA at all. It works on serotonin. It's a partial agonist at the 5-HT1A receptor. It's a totally different approach.
The slogan painted on the side of the bus says, "No sedation, no addiction."
And that's the beauty of it. It doesn't make you sleepy. It doesn't interact with alcohol. You won't get addicted or have a dangerous withdrawal. It's the responsible, sensible choice for long-term anxiety maintenance.
What's the catch?
The catch is the license plate. It takes 1 to 2 weeks, sometimes longer, to start working. If you are having a panic attack right now, the bus is useless. It hasn't even arrived at the bus stop yet.
The bus is slow.
The bus is slow, but it's safe and reliable for the long haul. It's the tortoise to the benzodiazepine hare.
I love that. A perfect contrast. Okay, from the chill-out lounge to the complete opposite end of the spectrum, I can hear electronic noises and loud music coming from over here. Now coming to next slide.
Welcome to Slide 9, Amped Arcade. This place is all neon lights, loud 8-bit music, and it's full of wide-eyed kids playing video games with incredible focus. This has to be CNS stimulants.
Right. We are talking about treatments for ADHD and, in some cases, narcolepsy. Drugs like methylphenidate, which is Ritalin, and amphetamines like Adderall.
The central attraction here seems to be a prize claw machine. You know those games in an arcade where you use a joystick to try and grab a stuffed animal with a claw?
Except this machine isn't grabbing stuffed animals. If you look closely, it is grabbing and then dropping massive amounts of gold coins.
And the coins are labeled with our worker symbols DA and NE.
Dopamine and norepinephrine. Stimulants work primarily by increasing the release of these two chemicals from the nerve terminals. They essentially force the prize claw to dump all its coins into the synapse, and they also block the vacuums that would normally clean them up. So you get a flood of DA and NE.
And the kids playing the games are hyper-focused.
That's the famous paradox of stimulants in ADHD. People always ask, if you give a hyperactive kid speed, shouldn't they just bounce off the walls even more?
Right. It seems counterintuitive.
But in many cases of ADHD, the problem is thought to be that the signal in the prefrontal cortex is too weak. There's too much background noise. So the brain jumps from one thing to the next, constantly seeking stimulation. By boosting dopamine, the reward and focus signal, and norepinephrine, the alertness signal, you dramatically improve the signal-to-noise ratio. The noise fades away, and the kid can finally focus on the game.
But I'm looking at the kids in the background, and there are some side effects depicted here. There's a clock on the wall showing it's 2 a.m., and a kid is lying in bed with his eyes wide open.
Insomnia. Classic side effect. If you play in the arcade too late in the day, you can't shut your brain down to sleep. The power generator is still running at full blast.
And on the side of the prize claw machine, there is a sign that says, "Do not feed appetite suppression."
Stimulants kill your appetite. Norepinephrine puts your body in fight or flight mode. You don't stop to eat when you're fighting a tiger. For kids who are growing, this can be a serious issue, potentially leading to growth retardation if they aren't eating enough calories.
And I see one kid holding his chest. His heart is literally drawn, beating out of his shirt, like in a cartoon.
Tachycardia and increased blood pressure. Norepinephrine speeds up the heart. It's something that needs to be monitored.
Now, over in the corner, there's a kind of lonely-looking arcade cabinet. It's not as flashy. It's labeled ATOM.
That stands for atomoxetine. We can call it the atom machine.
It looks different. It's not a prize claw machine dumping coins.
No, it's a skill game. Atomoxetine is a non-stimulant medication for ADHD. It is a selective norepinephrine reuptake inhibitor, or SNRI. It boosts the NE by breaking the norepinephrine vacuum, but it doesn't really touch dopamine and the reward centers of the brain.
The sign on this machine says, "No abuse potential."
Exactly. The prize claw is potentially addictive because that big dump of dopamine feels good, it's rewarding. The ADA machine helps you focus by boosting any, but it doesn't give you that euphoric rush. It's a great alternative for parents who are hesitant to give their kids stimulants or for adults who might have a history of substance abuse.
So prize claw for the immediate, powerful effect, but with abuse risk, versus the ADA machine for the safer, non-addictive, but maybe less potent route.
That's a very good way of summarizing it.
We have one last zone to visit in the park. It looks much calmer over here. It looks like a garden. Now coming to the next slide. This is slide 10, the memory maze. It's a beautiful, intricate hedge maze, the kind you'd see at an Old English manor. This must represent Alzheimer's drugs.
The goal here is navigation. Memory is about finding your way back to a piece of information, following a path. In Alzheimer's, the maze itself starts to die. The hedges wither, the paths become overgrown and disappear. Our goal with these drugs is to keep the maze navigable for as long as possible.
I see some gardeners working on the hedges. They're wearing overalls with name tags: Dunpeasel, rivastigmine, and galantamine.
These are the acetylcholinesterase inhibitors.
That's a big word.
Let's break it down. Acetylcholine is our strongman. Esterase is the name of the enzyme that breaks them down. An inhibitor means we stop it. So these drugs stop the breakdown of acetylcholine.
And they're holding spray cans labeled enzyme blockade.
Remember the strongman, acetylcholine. I told you way back at the beginning that he was also the memory manager. In Alzheimer's disease, the neurons that produce acetylcholine die off. The strongman is disappearing. These gardeners spray the blockade to stop the breakdown of whatever little acetylcholine is left. They keep the strongman on the job for longer.
And the visual effect of the spray is really nice. There are beautiful butterflies flying all around the hedges where they've sprayed.
The butterflies represent memories. By preserving acetylcholine, we allow the butterflies to thrive a little longer. It's important to be clear. These drugs do not cure Alzheimer's. They don't stop the hedges from dying. They just tend the remaining garden to make it function better for a while. They slow down the forgetting.
But the gardeners themselves look a bit green in the face, a bit nauseous.
That's the main side effect, cholinergic excess. Remember, acetylcholine also controls your gut motility and secretions. If you boost it systemically, you get nausea, dizziness, diarrhea. You're boosting the strongman everywhere, not just in the brain's maze.
I see. Now, in the very center of the maze, there is something truly epic happening. There is a wizard.
The wizard represents a different drug, Phenytoin.
He is wearing long blue robes, holding a staff, and he is casting a magical blue shield. And he is using that shield to block a giant, terrifying fireball that's about to hit the center of the maze.
The fireball is labeled glutamate fireball. And below that, it says excitotoxicity. This is a completely different mechanism of the disease. In moderate to severe Alzheimer's, you have too much of another neurotransmitter, glutamate. Glutamate is usually the main excitatory go signal in the brain, but here it's like a forest fire. It overexcites the neurons.
That's too much of a good thing.
Way too much. It allows a massive toxic amount of calcium to rush into the cells, and the neurons literally burn out and die from the overstimulation. We call it excitotoxicity.
So the fireball is the brain burning itself out from the inside.
Yes. And the wizard, Phenytoin, is what we call an NMDA receptor antagonist. The NMDA receptor is the main gate that glutamate opens. The wizard puts up a shield. He gently blocks that receptor just enough to stop the toxic fireball, but not so much that it stops normal, healthy learning signals. He protects the remaining maze from being scorched.
So for mild Alzheimer's, we use the gardeners like Dunpeasel to tend the hedges. And for more severe Alzheimer's, we call in the wizard, Phenytoin, to stop the fire.
Or very often we use both at the same time. They work on two different parts of the problem. A gardener and a wizard working together to save the maze.
Now coming to next slide. Well, we have reached the exit of Synapse City Fairground. That was exhaustive and amazing.
It's a big park, and honestly, we only visited the main attractions. There are many other little rides and food stalls we didn't even get to.
Let's do a quick recap of the tour. We started at the main gate, realizing we have to perform a pharmacological heist, smuggling L-Dopa past the BBB to fix the rusty wheel of Parkinson's.
With Carbidopa as our getaway driver who stays outside.
Exactly. Then we saw the dangers of the messy tricycle gang in the haunted house of TCAs and the explosive cheese reaction in the wine cellar of MAOIs for depression.
We stabilized the terrifying bipolar coaster with a very narrow window lithium battery.
We chilled out in the GABA tea lounge with the benzodiazepines, got hyper-focused in the amped arcade with the stimulants, and finally, we wandered through the beautiful but fading memory maze of Alzheimer's.
When you lay it all out like that, using these metaphors, you realize that All of psychopharmacology is just managing these 5 or 6 key workers. We are either trying to help the mechanic, dopamine, or calm down the strongman, AC, or boost the mood tech, serotonin, or regulate the power generator, NEE.
And the tools we use, the drugs, are just that. They are tools. A rope, a clamp, a battery, a shield, a vacuum smasher. They are magic. They are just mechanical interventions in a biological machine.
That's the perfect takeaway. The brain is incredibly complex, yes, but it's not unknowable magic. It's an understandable system of checks and balances. And these drugs are our first, somewhat clumsy attempts to nudge that system back into balance.
Before we go, I have one thought that's been bugging me throughout this whole tour. We've spent this entire hour talking about fixing the rides. Fixing the broken wheel, stabilizing the coaster, tending the dying maze.
Right. Restoring normal function.
But if we know how to manipulate these workers so well, if we can import dopamine to make movement smoother and boost norepinephrine to make focus sharper, what happens when we stop just fixing broken rides and we start trying to build new ones?
You mean cognitive enhancement?
Exactly. What happens when we use the tools from the Amped Arcade, not for a diagnosed case of ADHD, but just to be smarter, to score higher on an exam? What if we use the memory maze spray not for Alzheimer's, but to try and learn a new language in a week? As we master the mechanics of the fairground, are we going to become architects of our own consciousness? Or are we just going to overheat the generator and burn the whole park down?
That is the ultimate question, isn't it? The line between therapy and enhancement is getting blurrier every single day. And I think our safety inspector, GABA, might need to work some serious overtime in the coming decades.
A huge thank you to everyone for joining us on this tour of Synapse City.
It was a pleasure. Drive safe on the way out.
See you on the next deep dive.